University of Washington and Fred Hutch Cancer Center. With me today is my colleague, Dr. Renata Urban, and we will be moderating this session this morning. We're really excited. Welcome to our second annual Gynecologic Cancers Patient and Caregiver Education Program. Today, we're going to be focusing on ovarian cancer survivors, although all patients are welcome no matter what. We've put together a really exciting agenda that's very focused on patient-focused needs and interests, and really looking forward to presenting all this information to you. It's meant to be interactive, which is that we want to hear what your thoughts and your questions are. So all of our speakers have time, or hopefully will have time at the end of their talk for questions, and we'll go through some of those housekeeping on how to do that as well.
Good morning, everyone. I'm Renata Urban. I'm a gynecologic oncologist. I work with Dr. Gray at the Fred Hutch Cancer Center and University of Washington. Thank you all for joining this morning. I do want to start with a land acknowledgement. The Fred Hutchinson Cancer Center acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Squamish, Tulalip, and Muckleshoot nations. And we're very grateful for the privilege of basically being able to practice here.
Okay, we can go to the next slide. So we introduced ourselves. Thank you. Good morning. So here's some housekeeping for everybody. So this event is going to be recorded. It's recording now. The link to the recording will be shared with all registrants in a post-event email a few days after the event. Please post your questions using the chat function. We'll hope to get it to as many as possible. And if for some reason we don't get to some really key questions, we can always try to answer them post program. If you end up accidentally leaving the Zoom webinar, you can rejoin by clicking the link sent to you in the event details email. And after the event, we really want to hear back from you about what you liked, what you wanted to improve upon, what you might want to look forward to in the future. So please complete the event feedback form.
This is our agenda for this morning. We're very grateful to be joined by many of our partners and talking about elements of gynecologic cancer care, again, really focused on ovarian cancer. We're going to start with Dr. BJ Rimel, who'll be talking about novel therapeutics, including new drugs, new ideas. Dr. Jen Burzawa, who will talk about surgical management of newly diagnosed ovarian cancer. And Dr. Barbara Norquist, who will then cover genetics and gynecologic cancers. We'll have about a 10-minute break for a bio break to get some coffee, to refuel. Then I will be joined by Dr. Donna Berry, who is a professor in our School of Nursing, to talk about the management of side effects. My co-leader, Dr. Gray, will then talk about understanding clinical trials. And then we're very happy to be joined by Shanon Zorrilla from the National Ovarian Cancer Coalition and Tracy Moore from the Ovarian Cancer Research Alliance to talk about issues unique to this disease process. And we hope to close out to get everyone off to a weekend lunch.
Okay. So I think, Renata, with that, you want to just give a quick introduction of Dr.
Absolutely. Yes. So I'm very, very happy to be introducing Dr. Bobbie Jo, or BJ Rimel, this morning. Dr. Rimel recently joined our division as our division head, coming here from Cedars-Sinai in Los Angeles. She is an internationally known gynecologic oncologist for her specialty in gynecologic cancer and clinical trial development. She's been what's called the principal investigator, or essentially the lead physician scientist, in leading many of these trials, and has spoken at many national and international conferences. I think on a personal level, it's been such a privilege to have her join our division. She brings such a wealth of intelligence, compassion, and smarts to our division. And we're really happy that she and her family were willing to forego a little bit of sunshine and join us here in the Pacific Northwest. So with that, Dr. Rimel, please.
Thank you, Renata, for such a kind introduction. It's an absolute joy to join the group here. And I'm going to take a second and share my screen. And I'm going to switch to, bear with me. There's always a moment in the slideshow where you're like, is this going to work? Yes. Okay, here we go. Everybody can see?
Yes, perfect.
Yes, absolutely.
Fantastic. Okay, so I was given the privilege of talking about my very favorite topic today, which I know should be my children, but really is chemotherapy and the development of novel therapeutics. Um, I wanted to begin my discussion today with you guys by talking about the names that we use and the terminology that we discuss when we're talking about the different therapies for cancer. I wanted to talk about some of the newer kinds of cancer therapies, including targeted agents, immunotherapy, and antibody drug conjugates, and a little bit on what's new and how I can get it. But I think that if we really start from the basics of what the mechanisms of action are, how these drugs work, how we talk about them, that it gives us a lot of basis for which to be informed and also to ask questions more carefully of the science and of each other. So this is my plan for our time together today. I'm going to discuss what's chemotherapy, what is a targeted agent, what's immunotherapy, what are antibody drug conjugates, and what's new and how can I get it. Okay, so what is chemotherapy? Chemotherapy has been the backbone of cancer therapy since the 1940s. And it turns out that chemotherapy is actually a drug designed to cause cell death by inhibiting critical cellular processes like replication and division. It causes more cell death in cancer cells and less cell death in non-cancer or normal cells, but normal cells are still affected. So chemotherapies come in a variety of flavors, and they have a lot of ways to disrupt cellular growth. We have antimetabolites that limit the cell from creating new things like DNA or RNA. We have alkylating agents, which are some of the very first drugs that were ever developed, and they bind directly to cellular DNA and prevent it from being read, repaired, or replicated. Mitotic spindle and microtubule inhibitors prevent the cellular skeleton from being able to do its expand and contract, which affects division and other cellular processes. Topoisomerase inhibitors prevent DNA from relaxing enough to be read by the internal mechanism of the cell that allows the cell to grow and divide. And then we have some other medications that are reactive oxygen creators that actually develop other molecules, reactive oxygen species, that go in and break apart either DNA or protein. And all of these different mechanisms may be utilized by one drug, or one drug may have only one of these activities. Normal cells are able to ignore, repair, or kick out these drugs, but cancer cells are weakened in a variety of ways. And that is why chemotherapy preferentially works to destroy cancer cells. So if chemotherapy is so effective at killing cancer cells, why do we have to give it so often? This is a question that I get a lot in my office. Why are we thinking about doing so many treatments? And it's because chemotherapy only kills a proportion of cancer cells each time it is given, and multiple treatments are needed to actually get a real reduction of the cancer. So if a cancer is sensitive to a chemotherapy, meaning that it's this type of cancer is going to be susceptible to the activities of this chemotherapy, we're going to give it and a proportion of the cells will die. But we have to give it multiple times to get to a place where there aren't any cancer cells left that can regrow. So chemotherapy was developed, as I mentioned, back in the 1940s and continued into the 1990s. And there have not been a whole lot of new intravenous chemotherapy drugs since the 1990s. These agents, however, still represent, in most cases, the most effective way to kill cancer cells. And so we rely on these a great deal. I'm going to move on to what is targeted therapy. So this is a topic that gets, or a term that gets used a lot, and I want to really define it for our purposes. Targeted therapy is a drug designed to affect a specific target that causes cancer cell death, like exploiting a weakness. So instead of like in chemotherapy, where we have a generalized action where all the cells are likely to be affected, a targeted agent or targeted therapy is designed to act in a very precise location on a very precise weakness of the cancer cell. And the goal is to avoid having problems or off-target effects, side effects caused by that drug. There are many new and newer targeted therapies in gynecologic cancers, and I want to highlight a couple that are really popular right now that are showing some great results. PARP inhibitors, olaparib, niraparib, and rucaparib, each have been approved in different methodologies, although rucaparib currently is not available for GYN cancer. But these drugs are available and exploit a particular weakness of ovarian cancer cells called HRD. Another therapy that's targeted in GYN cancers are these tyrosine kinase inhibitors. These are multi-enzymatic inhibitors. They affect several different enzymatic functions of the cell. Lenvatinib and cediranib are ones that have been studied in ovarian cancer, and while neither are at this moment approved in ovarian cancer, there is emerging evidence that both of these may have targeted effects and may be part of our regimens coming up in the future, specifically in specialized or more rare types of ovarian cancer like clear cell carcinoma. The next drug that I wanted to sort of briefly talk about is a CDK4/6 inhibitor called palbociclib. Palbociclib is a very targeted agent originally developed in breast cancer that we are seeing some early effects in endometrioid cells, or some types of ovarian cancer are endometrioid ovarian cancer. And this drug is being studied in those areas and is an emerging therapeutic. And last but not at all least, aromatase inhibitors. And I've only listed letrozole, but there are several others. Aromatase inhibitors affect or target the estrogen receptors or the development or processing of estrogen. These drugs, initially developed also in breast cancer, are now extremely useful in lower grade ovarian cancers where estrogen receptors are super important. And so a lot of low grade ovarian cancers benefit from these anti-estrogen drugs of aromatase inhibitors, letrozole being the most common that we use. Oh, look, I had all these cool things and I forgot because I ran my mouth instead. All right, what is immunotherapy? We're going to move on to another of my favorite topics. All right, immunotherapy is a drug or antibody designed to enhance or suppress the immune system to effectively fight cancer cells. Immunotherapy is one of the newer things that we're going to talk about, more recently developed and much more recently discussed in ovarian cancer. So immunotherapy, in the most classical sense, is the use of something called a checkpoint inhibitor, and this checkpoint is PD-L1 or PD-1. And you can see from the diagram, PD-L1 lives on the cancer cell, and PD-1 lives on the lymphocyte or the immune cell. And it turns out that the interaction of these two proteins can make an immune cell ignore a cancer cell. So what's supposed to happen is the immune cell recognizes the cancer cell and actively destroys it. That's how our bodies keep us safe from cancer all the time. Checkpoint inhibitors are designed to wake up the cancers or wake up the immune system by removing one of these inhibitory protein interactions. Another type of immunotherapy is a CTLA-4 inhibitor. Imiplimab is the most common of these, and that inhibits a different mechanism, but very similarly on the lymphocyte itself to wake it up to the presence of the cancer cell. There are many, many more immunotherapies in development currently, but these are the only two that we have data on in ovarian cancer. Currently, most of our data in ovarian cancer is with pembrolizumab. There is emerging data that pembrolizumab or this immune checkpoint inhibitor in combination with chemotherapy may be an effective mechanism for recurrent platinum-resistant ovarian cancer. And recent data from the ESMO Congress, where this was presented, suggested that there was an improvement in progression-free survival with that regimen. The paper is not yet out, so we don't have that to evaluate at this moment, but it's coming shortly. We know that these new combinations of chemotherapy and immunotherapy bring a lot of improved responses. And I want to give an example from endometrial cancer of what we hope will start to emerge in ovarian cancer as studies are ongoing. In endometrial cancer, this is uterine cancer, we were able to see that the combination of chemotherapy and immunotherapy provided a significant improvement in overall survival compared to chemotherapy alone. And one of the ways that we evaluate that is by looking at these curves of the two populations who received different drugs. And what we see on the purple line is that those patients that got the immunotherapy with their chemo had more of a benefit than the patients who did not get immunotherapy with their chemotherapy. And so now this is our standard. And as you can see, this is pretty recent data. So now I'm going to talk about the antibody drug conjugate. So these are the biggest and newest things that we have going on, and I'm going to spend some time talking about their construction, their mechanism of action, how we think about them, and how we can pursue getting them for patients that it's appropriate. So an antibody drug conjugate is an antibody, which everybody remembers is a protein, bound to a chemotherapy drug designed to bring a specific target on a cancer cell, bind a specific target on a cancer cell, and deliver the chemotherapy directly into the cell. So an example of an approved antibody drug conjugate, which we often call ADCs, is mirvetuximab soravtansine. So mirvetuximab, which is we're going to use its shorter first name, is an antibody. And you can see that an antibody looks a little bit like a Y. The two up parts of the Y are the parts that bind to the target protein somewhere in or on the cancer cell. The part that's the stem of the Y is bound to molecules of chemotherapy. And unlike in chemotherapy that we normally administer intravenously, each chemotherapy molecule is just sitting in solution. In an antibody drug conjugate, multiple molecules of chemotherapy are bound to the base of this antibody. So we get more payload, more of the drug being delivered to the target. And how we talk about that is the drug antibody ratio. So for mirvetuximab, you can see there are 4 stars attached to the stem of the antibody. Those 4 stars represent 4 molecules of maytansinoid, or DM4, which is a microtubule inhibitor. And you may remember from the beginning of the talk that a microtubule inhibitor is a type of chemotherapy, a flavor, if you will, of chemotherapy that affects a cell's ability to grow and divide and do cellular functions. So the way that mirvetuximab, as an example, works is the antibody binds to folate receptor alpha, which is on the surface of the cancer cell. It's represented in little yellow triangles on the surface of the cell. What happens then is when that binds, our cells know that when an antibody binds to the surface, it should bring that antibody inside. It's called internalization. And that bringing of the antibody inside brings that payload, that chemotherapy that's attached to the stem of the antibody is brought inside. Because folate receptor alpha is expressed on cancer cells and not expressed on non-cancer cells, this is a targeted approach. This allows us to really focus on cancer cells and hopefully not get chemotherapy inside non-cancer cells. And that's basically how that mechanism works. It has taken us a lot of complicated science to get to this point, the ability to design antibodies, to get the chemotherapy to stick on to the end, the ability for the chemotherapy to be able to be released into the cell. It's not helpful if the chemotherapy just stays on the end of the antibody and doesn't get released. That's why all those little cleavable linkers are there, attaching the stars to the base of the antibody. That's really important. And the ability for that cleavable linker to know just when to let go is incredibly important. So a lot of complicated chemistry and science has gone into the development of these agents. And this is actually one of the first ones. We are beginning to see our second and third generation of the antibody drug conjugates. There are other antibody drug conjugates approved in gynecologic cancers. The one I just talked about, mirvetuximab, is approved in ovarian cancer. It's approved for folks whose cancers express or have that folate receptor alpha on the surface. So it's really important that we have that information, and that test is actually done on the tumor tissue that's gotten either at the time of surgery or from a biopsy. And that tells us if that protein is present in sufficient amounts for the drug to be likely effective. There are other antibody drug conjugates that have similar mechanisms, and I'm going to list a few of them here because they are really interesting, also really powerful. Relevant to ovarian cancer first is trastuzumab deruxtecan. This binds to HER2. So instead of folate receptor like the one we just saw, this antibody binds to HER2. HER2 is a protein that is present in many cancer cells expressed on the surface. The chemotherapy that's attached to this antibody drug conjugate is a topoisomerase inhibitor. So it's different than the one from mirvetuximab that was a microtubule inhibitor. This does something very different. And tumors need to have a sufficient amount of this HER2 protein. We say it's 2+ expression, but many GYN cancers will have this, not all, but many. And it's a test that we can now do for our patients looking at their prior specimens, and we can retest for this if it wasn't tested for at the beginning. This drug has been associated with improvements in response. We don't have overall survival data from these early studies, but what we do know is that for tumors that express 2 or 3+, meaning a middle amount or a lot of HER2 protein, that the response rates, or the amount that the tumor will shrink after giving a patient this drug, has been quite dramatic. And we see response rates of 50 and 60%, which is great. You're seeing tumor shrinkage with this. Another antibody drug conjugate that we are using in GYN cancer that is also very interesting is tisotumab vedotin, which sounds like Finnish to me, but that's what it's called. It's an antibody to tissue factor, which is expressed more preferentially on HPV-associated tumors like cervical cancer, but may be expressed in other squamous cell carcinomas, such as squamous cell carcinoma of the ovary. And there are a few case reports where this has been used. Tissue factor antibody is then linked to an MMAE payload. MMAE is very similar to the maytansinoid and is an antibody, or a microtubule inhibitor rather, and it affects the cellular function around microtubules. This protein, tissue factor, is present in almost all cervical cancers, and so that is where it is primarily being used, and it is approved for cervical cancer. There are several other antibody drug conjugates in development. B7H4 is a protein that's widely expressed on ovarian cancers and on endometrial cancers, and those studies are ongoing. And TROP2, which is also very commonly expressed in GYN cancers, ovarian and uterine. And we actually have studies ongoing at the UW Fred Hutch looking at TROP2 as well as Rina-S. So those are drugs, antibody drug conjugates that are in development, and for folks interested in clinical trials may represent an opportunity for them to get those drugs early. As I mentioned, how can a person get access to these new drugs? So basically, participation in clinical trials provides an opportunity to try new things. Participation allows for not only the patient to get access to new drugs, but for science to advance for the future. It's important to note that not every drug will progress from discovery to approval. This phases of clinical trials diagram that I've placed here is the only process for drug approval in the US and EU. We're not allowed to just pick a drug we think will work and give it to patients and then get approval. We have a complicated system of regulatory and scientific mechanisms to prevent bad drugs from getting moved forward and to avoid harming patients in the process of clinical trials. So this reason that this exists is to protect patient safety and to allow us to do the very best, cleanest, and most safe science to provide future treatments for our patients. If you are interested in participating in a clinical trial, the way to do that is either to call us. I've put the numbers at the bottom here. This is the Fred Hutch website where you can get information from our team about what trials we have open, or to have a clinical chart screened for a clinical trial. So one of the things that we're able to do is have a meeting with a patient, have a consultation, look at their chart and their history, and try to figure out what clinical trial might be a good fit based on the mechanism of the drug, based on whether or not they're eligible, whether or not we can match them to a good therapy. And we can do this for any patient. We have lots of clinicians able to do this. And so I would encourage anyone that's interested to reach out to consider participation in a clinical trial. So that concludes my talk and discussion, and I've left what I hope is sufficient time for questions. Those who know me know I love questions, so I really do hope that you will either put some in the chat or speak up. And thank you for letting me talk to you this morning.
Well, that was excellent, Dr. Rimel, BJ. Really amazing overview, and it really is almost emotional for me to have you go through this process, because I've been practicing for 25 years, and when I started, we had none of these targeted therapies available for ovarian cancer patients, and I feel like I have firsthand been able to see how we've been able to improve patients with ovarian cancer's lives with the addition of all these really exciting therapies. It's so amazing to be able to move beyond just chemotherapy. With that, let's see. I think we might have a first question. Thank you. Yes, please. So this is from a chat. So saying, is Avastin considered a targeted therapy?
Great question. Yes, Avastin is considered a targeted therapy. It's actually an antibody, like the antibody drug conjugates we talked about, but it's just an antibody. So it's an antibody to VEGF, which is a protein present on the surfaces of many cells that have cancer, especially in ovarian cancer. It's also present, VEGF is also present on other cells. So it's targeted, but does have some what we call off-target effects.
I have a question for you. So, how do practitioners, your oncology providers, how do they decide which of these therapies? Is that something patients have to kind of come and ask about, or how are providers kind of sorting through what's going to be the best therapy for them?
It's a great question. So there are a couple of mechanisms I think that we as providers use to determine what the right treatment for the right patient is. Some of that is done by reading the science. So all of us spend a lot of time learning what's new and what's happening. We also have clinical care guidelines provided by the National Comprehensive Cancer Network that allow us to strategize about what drugs are the best, or what the best science is for each disease in its line of therapy, meaning if the disease is new, whether it's come back, whether it's come back a second or third time. And then in addition to those sort of guidelines and available science, the other thing that I think practitioners are looking at when they're deciding on the next line of therapy is what makes sense for that patient. So a patient that's coming from a great distance may not want to choose a regimen that requires them to be at the hospital every week. They may want to choose a regimen that's equally good or reasonably similar that only requires them to come every 3 or 4 weeks. A patient may also wish to travel and may want something that's oral instead of intravenous. A patient may not want to lose their hair again and may elect to avoid things that cause alopecia. Those are all things that I think we think about when we're strategizing.
Thanks. Renata, you want to?
Absolutely. So I think we have a couple. Thank you so much, everyone, attendees, for submitting these great questions. So I'm going to go from the top, and please know that if we don't get to your question, we'll do our best to get through them quickly. One question. So why are targeted therapies like olaparib recommended after completing chemotherapy for ovarian cancer?
Great question. So the olaparib is recommended for HRD positive or BRCA positive tumors after completing first-line chemotherapy because in a very large study looking at those questions, it demonstrated improvement in progression-free survival when given after chemotherapy. So a lot of people ask me, why didn't you give me this instead of chemo? And the short answer is it just doesn't work as well.
I'm so sorry, Dr. Rimel. I'm going to tie that into a question lower down that says, are any of these drugs useful in preventing recurrence in ovarian cancer survivors with BRCA2 genes?
So olaparib is approved as well as niraparib for the prevention of recurrence after completion of primary therapy for BRCA2 positive people.
Excellent. Another question on ADCs is that they sound really exciting, and I completely agree. I think this is a really novel new class of drugs. Do you see the development of more of these in the next 10 or so years? Is this where the future of kind of the therapeutics field is going? Or I think as the participant noted, have we already found kind of the quote unquote low-hanging fruit?
Oh, that's such a good question. Okay. I think this is the beginning of the future, but the future is going to be even cooler than this. One of the best talks that I saw at the big cancer meeting that comes in June every year called ASCO was a presentation by Tim Yap looking at an mRNA vaccine. The vaccine causes the patient's body to create a particular molecule that then attacks the cancer. And that molecule is kind of like an antibody, but not exactly. The idea that we could give a single time point vaccine to target a cancer that would actually work with very few off-target effects and limited need for the patient to return to the center is incredible, right? I don't think that that's ready for prime time. Obviously, that was a phase 1 trial. I think that the antibody drug conjugates are a great way of helping us begin to better target, but we are not seeing at this moment curative therapy with antibody drug conjugates. So what I think we are seeing curative therapy with is with immunotherapy. So I imagine that the marriage of immunotherapy and antibody drug conjugates is probably going to be the next wave of therapy because always we're pushing for cure. So that's the next direction I think we're going to be heading in, if I had to guess.
Thank you. Another question is, are decisions on treatment options made by individual providers or tumor boards?
Depends on the system you're in and depends on the situation you're in. So a patient that's seeing me that has a pretty standard situation that we see all the time, that we have clear evidence for the next line of therapy, the decision is usually made with me and the patient based on the available data. But for a patient that maybe doesn't fit exactly what's happening or has a particularly confusing narrative or multiple tumors, for example, we may present them at our tumor board and discuss potential options and try to do a group think around that. But not every patient or every line of therapy is decided that way.
And I would echo to Dr. Rimel that I think that is in general the practice in our division and very similarly throughout the country, that oftentimes when it's for lack of a better word, straightforward case where there's a lot of evidence to support the next treatment, that oftentimes it's made between the provider and the patient, but the tumor board is a really excellent place for, as you described, groupthink. Next question, I think we have about 5 more minutes. So Ritu, please let me know if I should redirect. A patient who noted that they just got diagnosed with ovarian cancer and have had surgery and chemo, should she be reaching out to a research center?
That is a great question, and I have to answer it with an explanation of my deep bias for science. I am so on board. That said, yes, absolutely. A research center is a great place to ensure that every stone has been turned over when it comes to thinking about a person's cancer from a scientific perspective. Any research center is great. Of course, we are biased. We love our own, but really going to a tertiary care center, a place where they see a lot of the type of cancer that we're talking about, is a good way of making sure that a lot of thinking has been done about your particular situation.
Excellent. We have another question. So this is a patient sharing their personal experience that they just had their second occurrence of cancer and currently are starting Lynparza, which is also olaparib, and Avastin, which is also bevacizumab for maintenance. Given the high chance of another recurrence, the person's wondering kind of what treatment or drugs might be used on the next occurrence. And for someone like this, would they use carboplatin again? Would they use olaparib and bevacizumab again?
Really great questions. Without having a full picture of the entire clinical course, I can't give a complete answer, but I would like to sort of strategize about how we would think about this. So, for somebody that's had a single recurrence, the chance that their cancer will return again is very high, as this person has noted. What we try to strategize about by using maintenance therapy with olaparib and bevacizumab is hopefully pushing back that time of recurrence as far as possible. We know that if we can delay recurrence, that we can gain not only more time, but we gain more opportunities for other drugs. And then if, God forbid, the disease recurs again, as we expect it is likely to, the strategy that we use at the time is based on how did the patient tolerate that treatment? What do we know that's new about this cancer? Sometimes a new biopsy is required that may give us new proteins to think about new antibody drug conjugates, for example, or other types of therapy that may be relevant. And I would hold judgment on whether it's more carbo or more olaparib because time is passing in there, and I don't know what the right strategy will be until I reach that moment.
I'm just going to thank you for fielding that. And we definitely appreciate questions. We're not quite equipped to really handle individual medical questions just because, that's very complex. But if folks have more kind of generic questions, we're not really able to provide specific individual medical advice. So appreciate that. I think we have time for one more question, right, Renata, about CAR T cells.
Yeah, there's a great question here. Can
Yeah.
you tell us about CAR T cell use and any success for ovarian cancer?
So the fact that it wasn't in my talk is kind of the slow answer. Unfortunately, CAR T cells have limited data in ovarian cancer. Maybe they're going to be amazing. We just don't know at this moment. Most of the early CAR T cell studies in solid tumors, from a GYN standpoint, we're actually looking at cervical cancer. And that's due to a lot of complicated science. CAR T cells are amazing and incredibly powerful. And I do think that for solid tumors like ovarian cancer, we are going to hear more. But at this moment, I really didn't have anything interesting or clear to present. So I don't have a lot to say there. But stay tuned. Maybe next year.
Thank you so much. And I think just to address some of the additional questions, I think as Dr. Gray mentioned, it is always, I think we want to make sure we're not providing inaccurate information, which is why we're not necessarily addressing individual questions. But what I would encourage for patients who are on this, patients or family members, it is always okay to get a second opinion. I certainly tell patients that who are getting treatment with me, it's always okay to get a second opinion about what both the current therapy you're on, what potential options might be in the future. And so I think just in thinking about, if you're looking for more information, seeking a second opinion can be a great way to do that. Thank
And a
you.
lot of providers and us to provide telehealth as a second opinion too, if it's really like physically unable to get in. So great. All right. Well, we thank you so much, BJ. That was really excellent. Really, really great talk. I hope that everyone learned a lot. I always learn a lot when I hear you speak. So really appreciate your time. And we're going to move on to our next topic. Okay.
Thank you very much.
Oh, it is just my pleasure to introduce our next speaker. Dr. Jen Burzawa is an esteemed surgical colleague in our division. She has been with us, well, she originally was at MD Anderson down in Houston, Texas, and then joined us around 2019, 2020, I believe, and has just been an amazing partner as well. She's an excellent surgeon. She actually recently was certified of Certificate of Excellence in Robotic Surgery. She is incredibly well respected, a gifted clinician and surgeon, and she is going to talk to us today about surgical advances in ovarian cancer. And we'll give you a minute to pull up your own slide deck, but welcome, Dr. Burzawa.
Great, thank you. All right. Can everyone see that okay?
Yes.
Okay, great. So as Dr. Gray introduced, I'm one of the clinicians within our Division of Gynecologic Oncology at University of Washington. And today we'll be talking about the role of surgery primarily for newly diagnosed ovarian cancer. So I'm going to go through just briefly the kind of how do we even get to the decisions about who needs surgery and who needs chemotherapy for this disease. And so the initial presentation and diagnosis, I think, is relevant to how we as surgeons get to that point. So what we will be talking about today is epithelial ovarian cancer, which accounts for 95% of all ovarian cancers. And even though I'm going to use the words ovarian cancer in my talk, we are talking about fallopian tube, ovarian, and primary peritoneal cancer. As many of you know, unfortunately, most patients present with advanced stage disease, and that is because there's no known effective screening method to detect this at earlier stages. Here's just a brief slide about the various different stages of ovarian cancer. Again, I'm including this just because it's relevant to other conversations we'll have in this talk. So stage 1 is confined to the fallopian tubes and ovaries, stage 2 to the pelvis, stage 3 to the abdominal cavity, including lymph nodes and upper abdomen, and stage 4 for outside of the abdominal cavity or into the liver or spleen. There's a variety of different ways that patients end up coming to us. The most common is a subacute presentation. So patients present with relatively vague symptoms that are listed here. Occasionally, patients present with more acute and urgent needs that require emergent intervention or visits through the emergency room, as I have listed. And less commonly, we will detect this as an incidental finding when patients undergoing surgery or imaging for some other indication. This slide is a summary of a consensus statement by the Society of Gynecologic Oncology that is highlighting the symptoms that, albeit may be vague, but the conglomeration of these symptoms, as well as their duration and frequency, should prompt evaluation by a patient's provider for the possibility of ovarian cancer. So our own Dr. Goff performed a study that helped us detect that these symptoms are the most telling. So bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, which we call early satiety, or needing to urinate more frequently. The importance of this was the duration of symptoms, so less than 12 months, and occurring the majority of the days. This, of course, doesn't mean that somebody has ovarian cancer, but should prompt a thorough evaluation by their provider. So once there is a suspicion for ovarian cancer based on any of the things that we've already discussed, the next steps are workup, which typically includes a physical examination, some form of imaging, and often blood tests that we call tumor markers. If the findings after this workup, and I'm happy to go into more details about what that would include, but it's the findings for this workup show just an adnexal or ovarian pelvic mass that is concerning for cancer, but don't show any evidence of disease, referral should be made to a GYN oncologist. If there is findings based on symptoms or workup for metastatic disease, that should also prompt a referral to a GYN oncologist, and we'll go into why that's so important on the next slide. For those with just an ovarian mass, that often next step will be surgical exploration and removal of that and staging. For patients who have disease throughout the abdomen, the decision's a little bit more complicated about who would benefit from upfront surgery versus chemotherapy, which we would call neoadjuvant chemotherapy first. I just wanted to toot our own horn a little bit here about the importance of involving a gynecologic oncologist subspecialist in care. There have been multiple studies that have shown survival benefits and better outcomes, better surgical outcomes to patients who have a GYN oncologist involved in their care, ideally from the beginning of treatment before any decisions are made about surgery or chemotherapy. And this is included in the National Comprehensive Cancer Network guidelines. I want to acknowledge here, as we live in a state that has quite a rural population, that accessing a subspecialist, a gynecologic oncologist, can often be quite difficult. There are only 1,000 to 1,500 of us in the country, and on average, 20,000 patients diagnosed, newly diagnosed with ovarian cancer each year. So we, particularly in the state, are grateful for things like Dr. Gray mentioned, such as telehealth, to help make some of these decisions. So this is a great algorithm for decision making that we use to help decide which patients benefit from surgery versus chemotherapy. I'm not going to read this in any significant detail. The first thing I'm going to talk about is presumed early stage disease. So for a patient who's undergone workup and appears to have an adnexal mass or an ovarian mass that's suspicious for cancer, but no obvious evidence of spread of disease, the surgery would typically include obtaining fluid from around the belly, which we call washings, to look for cancer cells, and then removal of the mass, which is often the ovary. That gets sent to the pathologist intraoperatively for what we call a frozen section to confirm the diagnosis. And then we proceed with additional surgery, including hysterectomy, so removal of the uterus and cervix, removal of the opposite fallopian tube and ovary, removal of the omentum, which is this apron of fat that drapes off the stomach and colon, biopsies of the peritoneum, of normal appearing peritoneum, which is the lining of the abdominal cavity, debulking if appropriate. So if additional disease is found, even though initial imaging was negative, to remove all visible disease, and consideration for lymphadenectomy or removal of the lymph nodes. That is a little debatable in our field as to the importance of lymphadenectomy. It certainly can provide prognostic information. And about 30% of the time, patients who have clinically like stage 1 disease or disease confined to the ovary will have a microscopic spread to the lymph nodes. That, as I said, can provide information about prognosis. It can also sometimes help justify different chemotherapeutic drugs, maintenance therapy. And in certain cases for lower grade disease can dictate how much chemotherapy somebody needs after surgery. However, it is associated with increased risk of complications such as lymphedema, lymphocyst formation, and increases operative time. One other topic that has been consistent in our field for quite some time is the role of minimally invasive surgery, so laparoscopy or robotics in ovarian cancer. I would say that there's limited prospective data on this, but it is often utilized in our field, especially for early stage disease or disease that appears confined to the ovary. I think we need more research on this to help determine the true safety of this. It does appear that there's increased risk of ovarian rupture with minimally invasive surgery, and may be more difficult to assess the extent of disease spread throughout the various surfaces, but surgical outcomes seem to be improved, faster return to treatment and chemotherapy, and shorter hospitalization. I wanted to just briefly review some of the terminology that I'll use in the next section of the discussion. So for the purpose of this discussion, primary cytoreduction is so we call cytoreduction, which is debulking surgery, meaning we are removing all visible disease and all disease that we can feel. So primary cytoreduction means that is the first step of treatment performed prior to any chemotherapy. Interval cytoreduction is performed after some portion of chemotherapy. So we call that neoadjuvant chemotherapy. Typically in our field, that is performed after 3 to 4 cycles of chemotherapy. Patients would undergo an interval surgery and then receive additional chemotherapy afterwards. Complete cytoreduction means that all disease has been removed so that there remains no visible disease at the end of surgery. Optimal means that the disease each portion of disease that remains is less than 1 centimeter. And suboptimal is any disease that is greater than 1 centimeter that is left behind. So we will often include this in our operative notes to document the extent of surgery that was able to be successfully performed. So for patients with more advanced stage disease, so those who have spread throughout their abdomen on their initial workup and evaluation, the GYN oncologist is necessary to help make decisions about who should undergo surgery versus who should undergo chemotherapy. Patients with obvious stage 4 disease, so a large pleural effusion, disease within their liver or spleen, should generally receive chemotherapy first, as it was very unlikely that complete cytoreduction would be successful. Having the appropriate surgeon available is important, as we already discussed, so availability of gynecologic oncology and all other specialists that may be necessary. That the patient is medically well enough to undergo such a complicated and extensive surgery. For example, know that their nutrition status is adequate, they don't have significant medical conditions, no complicating factors such as newly diagnosed blood clots, and that we feel fairly confident that this is arising from the gynecologic organs such as the ovary and fallopian tubes. We generally do not perform biopsy prior to taking a patient to the operating room for suspicion of ovarian cancer and obtain the formal diagnosis at the time of surgery. If somebody is going to undergo chemotherapy first, then they do need tissue biopsy or confirmation of their disease prior to starting treatment. So just to go into a little bit more detail about decision-making around primary surgery versus chemotherapy in the United States, the guidelines, ASCO and NCCN, still state that primary cytoreductive surgery is preferred for patients with advanced stage disease who are good surgical candidates and have a high likelihood of achieving complete cytoreduction, and that neoadjuvant chemotherapy would be recommended for other patients. I have listed here, as I previously discussed, some of the other possible reasons why a patient might need neoadjuvant chemotherapy first. There is significant debate about why these guidelines continue to recommend primary cytoreductive surgery and whether or not there is truly oncologic benefit or survival outcomes, better survival outcomes for patients who undergo primary surgery versus chemotherapy. Most of the large randomized control trials and meta-analyses that have been performed in the past suggest that there is no benefit to primary surgery versus neoadjuvant chemotherapy in appropriately selected patients. And I think that's the key statement there. So here's some of the rationale for why we perform these quite large and extensive surgeries. The thought is that chemotherapy works best on small tumors because their blood supply is better and chemotherapy can therefore reach them more effectively. Also that they are more mitotically active and have less multi-drug resistant clones. By removing the bulk of the disease, patients' quality of life improves and they may be able to tolerate chemotherapy better. It may improve host immune response to assist with host attacking of the tumor. And by performing surgery, you get more tissue to confirm an accurate diagnosis and begin all of the important molecular testing that goes on in the tumor to help guide decisions about the most appropriate treatment regimen. So primary cytoreduction, we often use for patients who we think are candidates for surgery, we often use laparoscopy to help determine whether or not that surgery will be successful. This can be performed as one surgery like laparoscopy plus cytoreduction or as two separate surgeries. As many of you know, surgery for ovarian cancer can be quite extensive and can require other subspecialty services. Again, if we ask about the role of minimally invasive surgery, I think that's an ongoing debate and emerging topic, especially for advanced stage disease. The last thing I wanted to talk about was the role of peritoneal chemotherapy. Traditionally, we have had intraperitoneal chemotherapy, which has been around for decades. The patients that are optimal candidates for this are those who have completed a primary, so the surgery upfront prior to any chemotherapy. The decision and discussion would need to be had with the patients prior to them proceeding to the operating room so that the port could be placed at the time of surgery. And patients do not get chemotherapy in the operating room, just the port is placed. And then after surgery, their chemotherapy includes infusion of chemotherapy into the belly as well as through their IV or port. It is known to be more difficult to tolerate, but in older studies does show survival advantage. The NCCN guidelines still listed as a treatment option that should be considered. We have had many advances in treatment of ovarian cancer since these original trials were published. And to be honest, this has fallen out of favor due to some of these advances around maintenance therapy, such as PARP inhibitors and HIPEC, but still something to be considered and part of how the evolution of how we got to the next slide, which is HIPEC, which is stands for hyperthermal intraperitoneal chemotherapy. This has been around for some time, especially used to treat other malignancies such as GI malignancies or appendiceal cancers. And it is an ongoing area of interest for ovarian cancers who have disease spread similar to that of these gastrointestinal cancers. The NCCN and ASCO guidelines do state that they would recommend considering this as part of the treatment at the time of an interval surgery. So for patients, the patients who would be considered candidates are those that have had upfront chemotherapy and then are being taken to the operating room for interval surgery. That surgery would need to be a complete cytoreduction, so to no visible disease. And then the HIPEC would be administered at the time of their surgery. Patients then recover and go on to receive additional chemotherapy after surgery. This does significantly increase the operative time, the need for expert surgeons, as well as advanced postoperative care. And seems, although studies are varied, that there is increased, certainly short-term complications related to surgeries, and so patients need to be medically fit enough to be able to undergo such a prolonged procedure. This here at University of Washington Fred Hutch, we do perform these surgeries in appropriately selected patients with our surgical oncology colleagues. And so I'm going to leave it there and let Dr. Gray and Dr. Urban see if anyone has any questions.
Wow, that was excellent, Dr. Burzawa. Really nice overview and giving lots of excellent kind of detail and explanation. I know that patients do have access to their operative notes and stuff like that now, so hopefully this kind of helps you clarify some of these questions you've had. There's one question, and it'll probably be a little difficult to answer specifically, but it was about for patients who have a rarer subtype, for example, like granulosa cell tumors, are there different strategies regarding surgery in conjunction with chemotherapy?
I think, most of the talk that I gave today is for epithelial ovarian cancer. For most, so for the rare histologies, the role of surgery can be quite different depending on the patient's age, menopausal status, and fertility desires. Surgery is the mainstay of treatment for granulosa cell cancers, whether it's upfront or recurrent disease. And depending on the stage of the disease, chemotherapy would be used afterwards. I hope that answers the question.
Yeah. And then we'll just cut into Dr. Norquist. I'm just a teeny bit. Two questions. One is regarding the tumor marker CEA. And the question was, I know it's not quite surgery, but kind of in conjunction with, the question was, what is the tumor marker CEA and when is it appropriate for recurrence tracking?
So CEA is a tumor marker that's more relevant to GI cancers and colorectal cancer because often metastatic colorectal cancer can present similarly to metastatic ovarian cancer. We check this tumor marker for initial diagnosis, mostly to try to rule out or reduce our concern that this is not arising from the ovary. If it's not elevated at a patient's initial diagnosis, usually we would not continue to check it for follow-up and surveillance.
Excellent. Good. Well, I think we want to stay on time. That was really a nice overview. And again, if questions come up, Dr. Urban and I will be here throughout and can answer things. I think Dr. Urban answered a question about the HIPEC. It is heated. That's part of the H, is heated intraperitoneal chemotherapy. But I think we'll just say thank you to Dr. Burzawa. And we will now turn to our next speaker, Dr. Norquist, who I think is joining us. And Dr. Urban is going to introduce her. Welcome.
Good morning, Dr. Norquist. So Dr. Barbara Norquist, I feel I should interrupt by saying I'm actually very grateful to be in a division that is full of amazing, wise, just brilliant people that are known internationally for their expertise, but are on a personal level just exceptional human beings, as is Dr. Rimel and Dr. Gray. But Dr. Norquist is a internationally and nationally known expert in the, I think, assessment, the management of patients with both the genetic risk for ovarian cancer, as well as trying to find out the best strategies to evaluate these patients, try to look at strategies to prevent ovarian cancer in these patients, and really an advocate for the importance of genetic testing and screening in patients with ovarian cancer as well as their families. So Dr. Norquist, thank you so much for taking your time to be here this morning, and I'll give you a little bit of time to start sharing your slides. And I can see your slides, Dr. Norquist.
Excellent. You stopped me from saying that out loud. Good morning, everyone. Thank you for spending your Saturday with us. Gonna switch gears just a little bit and kind of talk about the importance of genetic testing for individuals with ovarian cancer and the impact of that potentially on their family as well. All right. So, guidelines for ovarian cancer from basically all of our various organizations, from the NCCN to ASCO to European organizations, all of them are in agreement that one of the kind of first steps when a person is diagnosed with ovarian cancer is to undergo genetic testing. And the way this tends to get described is both germline and somatic genetic testing. And so I'm going to explain what those terms mean and what information one gathers from those different tests and sort of how those tests are carried out. And then I might just say ovarian cancer kind of as shorthand as we're going through the presentation, but really that is kind of an amalgamation of ovarian cancer, fallopian tube cancer, and primary peritoneal cancer, all of which are essentially treated the same. And in fact, some have sort of advocated for renaming this like tubo-ovarian cancer. All right, so what exactly is germline and somatic genetic testing? So kind of starting with this little cartoon on the left, and apologies, I made this slide a long time ago, so maybe someday I'll try to make it prettier, but this is kind of my basic diagram. So the germline refers to the DNA that's present in every cell in your body. This is the kind of original DNA that you inherited from your parents. And if a person has a finding there, it's in every cell in their body. So there's my little cartoon to signify that that's every cell in your body. And kind of the most common ways to test for that are with a blood sample, a cheek swab, a saliva sample. Those are kind of all ways to get at testing for inherited genetic changes. Somatic testing refers to, like, soma means body, so it's a biopsy of typically a tumor, which is usually obtained by either surgery or kind of a percutaneous biopsy to get a sample of the tumor and test the tumor's genetics to see if there are acquired changes that have happened through the course of the cancer. If a person has, for example, a genetic change that's in every cell in their body, that change is also going to be in the tumor. So a tumor biopsy can also be a way to identify inherited mutations as well. And sometimes some additional testing is needed to sort of sort out where different things come from. So this is this is to explain how mutations are inherited. So every person has 2 copies of each gene. And the gene is kind of this basic unit of DNA that encodes a specific protein. And many of the proteins involved in DNA repair, when a patient has a mutation in one of those genes, that can predispose to cancers. So if, say this is 2 sets of parents and they're each going to pass on 1 copy of a gene to their child, if this little star kind of signifies the mutation. So if the mom passes this copy to the child, then that child will also have that same mutation that the mom had. Or just as easily, 50-50 chance, that child could get the copy of the gene that does not have the mutation. And then also just as easily, these mutations can be inherited from dads as well. And just because a mutation seems to predict gynecologic cancer risk doesn't mean that that men don't also have those same mutations, and they are equally likely to pass that on to children. It's just a little bit harder to see cancers in the family when it is mostly men who have the mutations. If you look at what proportion of patients with ovarian cancer have an inherited mutation, about 18% of patients with a new diagnosis of ovarian cancer will have a detectable mutation that likely contributed to their cancer forming and that was inherited from a parent. This is one of the highest proportions of any of the solid tumors. And for that reason, it's recommended that every person with ovarian cancer undergo this testing. And I will kind of explain the potential benefits of knowing about this. And again, most of the mutations are in BRCA1 and BRCA2, which is sort of our best known inherited genetic syndromes. And but there's a significant portion that are in other genes as well, like BRIP1, RAD51C, RAD51D, PALB2, and the Lynch syndrome genes. So what does this mean for a family? So this is a kind of classic diagram of a family structure. This is called a pedigree. And I don't know if you can see my little arrow kind of pointing here on the screen, but if this is like a set of parents here with a dad and a mom, and then these are the children, the offspring there. And this is the individual who's developed a cancer. That's why this dot is colored in and was found to have a BRCA1 mutation. So this person has, 5 direct siblings and 2 children. And so these are all first-degree relatives, which means that each of those individuals has a 50% chance of also having that same BRCA1 mutation. Because if you have, we know that one copy was transferred to this individual, and so each person, it's just a 50-50 chance. Sorry to be repetitive there. So what does that mean for a person if they find out they have a mutation in BRCA1 or 2 who doesn't have cancer? So say like an unaffected family member of a person with ovarian cancer, what can that person actually do about this? This is a paper just highlighting what the potential risks of cancer are. So there are substantial risks of breast cancer. This is just a graph showing the incidence of cancer over the lifespan, starting from kind of age 20 on the left up to age 80 on the right, and showing around a 75% risk of breast cancer. And then for ovarian cancer, BRCA1 carriers have around a 44% risk up to age 80. BRCA2 carriers, 17%. And while these risks appear lower than the breast cancer risk, all of us in this community know how serious ovarian cancer can be. And so we have a strong interest in preventing those cancers. So what can people do if they find out about this? So for the breast cancer risk, we do actually have highly effective screening for breast cancer with breast MRI and mammograms. There are also options for preventative surgery to remove the breast, and all of these services are available through Fred Hutch and UW. For ovarian cancer, and this could be a whole other topic, we unfortunately really do not have effective screening tests for ovarian cancer. So for this population who is found to be at risk of ovarian cancer, and if we know that and we know the kind of typical age of onset, we can perform a surgery to remove the tissue at risk prior to that person developing a cancer, and that is a highly effective strategy. The Fred Hutch has numerous cancer prevention clinics. The one that I work in the most is the Breast and Ovarian Cancer Prevention Program Clinic. In this clinic, we see patients who are found to have mutations in genes that predispose to breast and ovarian and endometrial and other cancer risks. And depending on their risk profile, that patient will meet with a specialist who might cover breast recommendations, a gynecologic oncologist who would cover ovarian cancer, endometrial cancer risks, and whatever other specialties they may need. We also have an embedded nutritionist in that clinic, as well as a genetic counselor. So it's a really wonderful multidisciplinary clinic that can help a person with this type of finding. This is the phone number for that clinic if anyone has family members who may need to be seen there. And I'll put the phone numbers on the last slide at the end too, so don't worry if you missed that. So if a person's going to get tested for inherited mutations, like what are the options that are available? And someday I'll retire this slide because no one's going to do these like lesser tests anymore. But if you have a known mutation in the family, like you know your mom's BRCA1 mutation, you can be tested for just that mutation. And this used to be like really the cheapest option. And so if you already knew where it was, you didn't have to do a big treasure hunt for it. By that same token, if you're from a family with Ashkenazi Jewish heritage, there are kind of three what are called founder mutations, which are mutations that are just much more prevalent in this population. And so if a person has known Ashkenazi ancestry, they used to start with these three tests for the three founder variants. And again, that strategy was to utilize this kind of limited resource. And then if that testing was negative, oftentimes that'll get expanded to a larger panel. Single gene testing is what we used to do for many years prior to being able to test multiple genes at once. And this was mostly BRCA1 and 2 testing. And I'll kind of show you a timeline of all of that too. And then by far the most common method for genetic testing these days is to use more advanced technology called next generation sequencing, where essentially we can test as many genes as we know about to look for various causes of ovarian cancer risk. And this is why we've moved beyond just talking about BRCA1 and 2, because there are so many other genes involved as well. How does a person get tested? So kind of our gold standard for this is to meet with a genetic counselor. And this is an individual who has specific training in genetics, who can really help explain this to people prior to undergoing genetic testing. They can help with testing family members. They can help track down results. They can help with insurance authorization. And they're trained to kind of order the most correct test. Potential cons to seeing a genetic counselor primarily is that they are limited in some communities, like it can be a limited resource, and insurance coverage can vary for this. If an individual has a cancer, their oncologist can also directly order this type of testing and then save the genetic counseling referral potentially just for explaining results that are either show an inherited mutation or that are confusing. This is the phone number for the Fred Hutch Clinical Genetics and Genetic Counseling Service. And again, I'll put that number in at the end as well. One of the questions that people sometimes ask me, or they'll have a family member who they think might have had testing, but maybe it was a long time ago. And I can sort of use this timeline to figure out what type of testing that individual may have had. So in 1990, Mary Claire King, who still works at UW, she comes to work every day and is still discovering genes for a variety of conditions. But she discovered the BRCA1 gene. And at that time, there was a big international race to try to sequence the gene so that people could be tested for it. And in 1995, a company was the first to identify the sequence to BRCA1 and filed a patent, and then also for BRCA2. So it was in about 95, 96 is when we had commercial testing for BRCA1 and BRCA2 mutations. And because there was a patent, one company was offering testing for that period of time. And that was the only way a person could get tested unless they had done it in the context of a research study. In 2009, 2010, the technology to sequence many genes at once started becoming more mainstream. And so a variety of other groups were kind of ready to do this testing as well, including other potential causes of cancer risk. And all of this changed in 2013. The ACLU sued this company who had the patent on the gene sequence, and that was actually a unanimous decision in 2013, which feels like rare to say that, but this court viewed that a product of nature could not be patented. You can't take a DNA sequence that exists and say you've invented something new. And this then led to a big explosion of genetic testing companies. So this has really decreased the price of testing. It's made it more available, and patients can get more comprehensive testing for multiple genes. So there are numerous companies now that offer genetic testing. So if reason to say that too is if a person had testing prior to 2013, it's unlikely they had testing for genes other than BRCA1 and BRCA2. So it could be if that testing was negative and you're still concerned about the family history, retesting is a very reasonable thing to do in that setting because up to 25% of mutations might be in genes other than BRCA1 and 2. Okay. So that was all the information kind of really focused on, okay, if a person with cancer has a mutation and family members have it and they want to prevent cancer, what can they do? Now I'll shift gears a bit to talk about what that mutation status means for the person with ovarian cancer. The BRCA1 and 2 genes, as well as like the other cancer risk genes like RAD51C and D and BRIP1 and PALB2, like all of those genes are really important to repairing DNA. And tumors with defective DNA repair, it's kind of a double-edged sword. Like the defective DNA is what makes the tumor form in the first place, but also can make it more susceptible to particular therapies like chemotherapy and a specific class of drugs called PARP inhibitors. And I know Dr. Rimel spoke about this as well, but PARP inhibitors impact like a different DNA repair pathway. So in cancers that have defective DNA repair, it can't rescue itself with the PARP DNA repair if you have that PARP enzyme blocked. And so these cancers are particularly susceptible to PARP inhibitors. And this is just a diagram from a review paper kind of demonstrating a little bit of how that works. If you get damage to DNA, such as with chemotherapy, this pathway on the left, you get a little break in the DNA, and then this PARP enzyme comes along and repairs it, and then that tumor stays alive. But if the PARP enzyme is inhibited, then the DNA cannot repair itself, and that cell can then die, which is sort of our goal with the anti-cancer therapies. For individuals with BRCA1 and 2 mutations, this was a really important paper that came out in 2018 and really changed our practice for individuals with inherited mutations in BRCA1 and 2. This was the SOLO-1 study. This looked at newly diagnosed patients who had had a surgery and chemotherapy and then were in remission. And patients either just went on observation, which was sort of our standard at the time, or they took 2 years of olaparib, which is a PARP inhibitor. And the individuals who took olaparib are kind of represented by this blue line. And if you're not used to looking at these type of graphs, what it shows is kind of the number of patients experiencing a disease recurrence or death over time. And you can compare the group that got no PARP inhibitor to those who got the PARP inhibitor, and the group who received olaparib lived longer and had less cancer recurrences. And then these are just several other studies with similar findings in patients who developed a recurrent ovarian cancer, but also had a BRCA1 or 2 mutation and received a PARP inhibitor. PARP inhibitors can also work for other conditions as well, not just inherited mutations. If a person has an acquired BRCA1 and 1 or 2 mutation or a mutation in one of these other genes that are critically important to DNA repair, can have a really similar effect to the BRCA1 and 2 mutation, and those tumors are also highly susceptible to PARP inhibitors. So testing the tumor for biomarkers is just one of many things that might happen with diagnosis of ovarian cancer. And one of the critical components of that is the sequencing, like we've been talking about, to look at acquired mutations in BRCA1 and 2 or other genes. And this pie chart on the right kind of demonstrates that, close to 30% of these tumors will have a mutation in a homologous recombination repair gene. So this group kind of goes right in with the inherited mutation carriers in terms of response to PARP inhibitors. Homologous recombination deficiency is a different kind of sequencing-based test of the tumor, and I've got, and I'll describe that more on the next slide. And this can also predict response to PARP inhibitors, kind of beyond just the presence of a mutation. Dr. Rimel spoke a lot about various protein tests that we can do on tumors now to look for drug and clinical trial eligibility with proteins like the folate receptor alpha and HER2, for which we have antibody drug conjugates for. And then microsatellite instability is another kind of sequencing-based test that can sometimes predict response to immunotherapy, and is another thing we can find out by sequencing the tumor. So homologous recombination deficiency gets talked about a lot in ovarian cancer. And essentially what this means is homologous recombination is the type of DNA repair that is done by the BRCA1 and 2 genes and these other risk genes that we're talking about. So if a person has an inherited or acquired mutation in the tumor, a somatic mutation in BRCA1 and 2, or in these other genes like RAD51D, RAD51C, those mutations cause homologous recombination deficiency because the tumor can't repair the DNA. You can also have what are called epigenetic changes, which is methylation of a gene can lead to its having decreased function, or that gene is not being utilized. So all of these things can cause homologous recombination deficiency. What HRD tests do is they actually measure the effects of having had defective DNA repair. And when you've had a tumor that can't repair its DNA, it leaves kind of characteristic patterns in the genome of that tumor that are sometimes referred to as genomic scars, because it really is an indicator of having had HRD at some point. And I tend to think of this like graffiti. You see these findings, you know that HRD was there at some point. What you don't know is if it's still there, because it's just the kind of downstream effect of having had defective DNA repair. If that mechanism gets restored, then the tumor may respond less well to chemotherapy or to PARP inhibitors. And so this is just kind of one more indicator that a PARP inhibitor may be beneficial, but it's not always, because we can't measure kind of real-time homologous recombination deficiency. Another question we get asked a lot is if repeat tumor sequencing is going to be helpful. And oftentimes, the main kind of drivers of PARP inhibitor response, like homologous recombination deficiency findings, microsatellite instability, BRCA, and other mutations, those findings tend to be so critical to the tumor that they don't tend to change much over time. The exception to this is if you're being worked up for a research study and there's a specific genetic change that they're looking for that may not have been tested for before, so kind of specific trial or specific drug eligibility, then that could be a reason to do that. But it's important to know that many times that can be new testing that hasn't been done before, can often be done on archival samples from the initial diagnosis or initial surgery. New biopsies are often not needed, but can be done oftentimes for clinical trials. All right, so these are kind of my two big take-home messages. One is that genetic testing can identify genetic risk in your family, allowing for effective screening and prevention for individuals who have not developed a particular cancer. And genetic testing can help your doctors treat your cancer more effectively and with more precision. So thank you so much for your time. And those are the phone numbers for those Fred Hutch clinics. And I'm happy to take questions. No idea how we're doing on time because I
Thank you
didn't.
so much, Dr. Norquist. That was excellent. And I also always learn from you whenever you give any talks. And we actually have about 10 minutes until our scheduled break. So I'm gonna go a little bit backwards in that I'm gonna spend some time getting to the questions that were addressed to Dr. Norquist and then hopefully circle back to some questions for Dr. Burzawa. So I think one question that had come up was had to do with since ovarian cancer is often not diagnosed in early stage, how well checkups are detecting ovarian cancer, and is it missed because it's difficult to diagnose? And I think we could think about this as like those who maybe have a mutation, but then maybe those who don't.
Yeah, and I mean, really for all comers, like those with genetic risk and those without, screening for ovarian cancer has been a really frustrating clinical problem. And part of that is because the high-grade serous cancers, they tend to start microscopically, probably mostly in the fallopian tubes, and then those cells can migrate out to the ovary or to other surfaces. And that can happen very early in the clinical course before there's a substantial mass that can be identified with imaging or before there's enough tumor present to raise a tumor marker. And that's part of why it's so hard for us to identify these cancers at an early stage or to have screening tests like ultrasound and CA-125 to have them make a really measurable impact on the course of disease. We always would love to diagnose something as early as we possibly can. And there's no question that that makes it easier to treat and easier on the patient. But if our goal is to prevent ovarian cancer outright, we cannot do that with screening because there isn't an identifiable precursor for ovarian cancer. Does that answer the question?
I think so. And I think to build on that, Dr. Norquist, another attendee asked about how relevant is CA-125 testing in that.
Yeah, I mean, CA-125 is kind of our best known marker for ovarian cancer. And for individuals that we know are at high risk, we will sometimes follow that over time or, kind of looking for trends to see if anything is kind of pointing towards a more concern or less concern. Or if there's a mass that we're following in an ovary, like we might use that as kind of a tiebreaker to decide if we should keep looking at it or if a surgery might be warranted. So we definitely use it. But there are many causes of false positive CA-125s, and you can also have false negative CA-125. So it's a far from perfect test. It's not recommended to test that routinely in those who are not known to be at high risk for ovarian cancer because the most common finding is a false positive and people actually get harmful things done to them in the course of trying to figure it out. And so national guidelines recommend against that. But for monitoring a specific situation or monitoring a known high-risk individual who's planning to have surgery anyway, we just don't know exactly when they're going to do it. That's where it tends to be more useful in the non-cancer setting.
I think another question that came up is there a resource to see a mapping between genetic markers and therapies that target them?
That's a great question. I don't know off the top of my head. I think, any of the kind of defective DNA repair and homologous recombination deficiency really kind of our mainstays with that are PARP inhibitors. But yeah, I don't think we have a nice chart for that. But anyone else know of one?
I think some of the commercial companies that do the tumor sequencing will sometimes provide a table listing the genetic alteration and whether there are available therapies, not whether it will be applicable for the patient in question, but based on the mutation.
Yeah.
But it's oftentimes fairly wide in scope. And I do think as a thought, this is certainly something I think worthwhile if you have your tumor tested to ask your doctor about the results and are there any available therapies based on that and are they appropriate for you? Dr. Gray, if it's okay, I'm going to turn next maybe to cover
Can
some of
we just do a couple? There's a couple questions. I think we had a couple with the BRIP1 mutation. There was a couple questions specifically. Is that okay, Renata? Sorry, I didn't mean to cut you off.
Absolutely. I just wanted to make sure we had a couple questions for Dr.
Yeah.
Burzawa.
Yeah, I just wanted, because I know that a couple questions came up about BRIP1 and risk of breast cancer. Maybe just take a little moment to address that.
Yeah, let me try to scroll up and see where those were.
I think what was risk of breast cancer and ovarian cancer if you have a BRIP1 mutation.
Got it. So the BRIP1 is some studies, kind of looking at just individuals with triple negative breast cancer, like you do find for cancer risk management for BRIP1 carriers, but oftentimes that can push a person into a category where they might qualify for enhanced screening with breast MRI. So if that is a question, that question can be addressed by a genetic counselor, or there are also clinics at Fred Hutch that assess a person's breast cancer risk and help them decide if they need more screening. There's a breast health clinic that can help with that as well as the genetic counselors. Yeah.
Great, thank you.
BRIP1 is also a homologous recombination deficiency gene, and so we hope that PARP inhibitors also work well for those with BRIP1, but it's harder to study because there's not as many individuals with those.
I just wanted to clarify one thing, because I think this came up, a question about if someone themselves has ovarian cancer and is found to be mutation negative, what are the guidelines for their daughter and their granddaughter for screening?
Yeah, that's a great question. If an individual has like one first degree relative, like a parent with ovarian cancer, we're always like reassured if the testing is negative in that individual with ovarian cancer, because we think the most likely thing is that they're probably in that 80% who does not have an inherited mutation. But some kind of older studies that didn't necessarily incorporate the genetic testing estimated maybe a twofold risk if you have a first degree relative with ovarian cancer. So somewhere in the neighborhood of 4% or so lifetime risk of ovarian cancer. And those are patients that we see in clinic too, and kind of go over all of their information carefully, looking at their age, their reproductive desires, and the entire family history to help determine, like, okay, does this individual need more genetic testing? Can we offer any sort of preventative treatments? And so those are really on a like kind of individual case-by-case basis, but we do see patients with that scenario in clinic to talk about it, because it's just so different for each person.
Thank you so much, Dr. Norquist, Burb. That was excellent. Really learned so much. And again, slides are all available. I know there's a lot of questions coming through. We're hoping to get through some of them. I do want to invite Dr. Burzawa back if she's available. If she's not, we can. Hi, Dr. Burzawa, thank you so much. I'm so sorry. I cut off the questions because I thought we were finishing at 10, and so I was nervous about that. My apologies. But an important question came up about the role of surgery in recurrence when patients have a recurrence. And if you could maybe just take a few minutes to talk about how we decide that or the role of that.
Yeah, and again, I think I'm going to feel this for kind of epithelial ovarian cancer. Some of the rare histologies, there is a more important role for surgery. This kind of has been addressed multiple times through large randomized controlled trials. And the data suggests that there's, in most cases, not a benefit to kind of a secondary surgery or kind of secondary debulking for most epithelial ovarian cancers. Again, that's simplified. That's not to say that it never comes up or it's never relevant, but doesn't seem to offer a survival advantage.
Excellent. So then I think, okay, let's see, a couple of questions have come through. I think we might save time. Let's see. Not aware where are we at with the questions. Comprehensive. Okay. So
left, but about to head to a break. So
yeah, let's do it. Yeah, I agree. Probably a good time for a break. Some of these questions are super important. We want to have time to really dive into them. Thank you, Dr. Burzawa. Thank you, Dr. Norquist, for joining us. I think this is we're at 10:40. We want to be mindful of everyone to take a little break, and we will return in 10 minutes at 10:50. And for our second half of the program, but we will get to the questions. Okay, thank you.
And talking about effects, but I am extremely privileged to be joined by Dr. Donna Berry. Dr. Berry is a professor in the School of Nursing. She has extensively researched on the role of communication, the role of patient-centered focus on side effects in cancer patients, and she has specifically been a huge support as well as a driver of research in this area, and has collaborated on projects in our division with Dr. Barbara Goff. Dr. Berry was very instrumental in our division starting essentially an online symptom review for our patients, for which I'm extremely grateful. So I'm very grateful to have her join me today. And Dr. Berry, please feel free to add anything that I might not have.
Thank you. Well, it's been a pleasure and an honor to work with the patients in gynecologic oncology and with the providers as well, because part of what we do is help providers understand what the patients have reported. And yeah, so it's been an honor for me to work. And even better than that, we know that it makes a difference. So it improves things for patients. So that's good. Thank you for inviting me.
You're very welcome. I'm going to go ahead and make sure I'm able to share my screen. And I'm in presenter mode. Dr. Gray, how am I doing there?
You look good. And I also want to just jump in and quickly introduce my esteemed colleague, Dr. Urban, who I've worked with for over 15 years. And I just am so appreciative of that I get to work with her every day. She is an excellent patient advocate, tireless, and has a passion about improving patients' care, particularly around side effects and toxicity. So really looking forward to this talk. I know that is very, very incredibly important in folks' journey. So thank you.
Thank you very much. All right. Well, we did our land acknowledgement. I think just to make sure that I again emphasize the gratitude that all of us have, that we are able to utilize the land from our that essentially were previously, owned and still owned by our tribal co-citizens. So I think just gratitude for that. So I would like to start with a definition of what's called survivor. And I actually found this when we did our first seminar that was focused on this, and why I wanted to bring it up is that the NCI, or the National Cancer Institute of the National Institutes of Health, actually defines survivor as one who remains alive and continues to function during and after overcoming a serious hardship or life-threatening disease. And most importantly, when talking about cancer patients, in cancer, a patient is considered to be a survivor from the time of diagnosis until the end of life. So even if you are struggling with your cancer, meaning your cancer's gone away and come back, you're still a survivor. We are still treating our survivors. And so I think it's important to have that context when we talk about both being a survivor as well as survivorship. Because survivorship, when it comes to cancer treatment, includes a lot of different symptoms. And some of these symptoms are cancer related, some of them are treatment related, some of them are all of the above. But the symptoms that patients and their families and their caregivers are struggling with are very real and very important to make sure that we talk about. And I do want to note today that we're not necessarily going to be able to cover all of the symptoms, but we really wanted to highlight both some of the ones that we as providers hear about enough, as well as provide you with some tools to talk about some of these symptoms, because it can be very challenging sometimes to communicate about them. So I wanted to start by talking about kind of living with and without ovarian cancer. And as covered by some of my colleagues, nearly 80% of patients who have what's called epithelial ovarian cancer, or the most common type of ovarian cancer, will present with advanced stage of disease, meaning the cancer has left where it started and spread to the abdomen, the pelvis, or beyond. And although more than 80% of such patients will have remission, about 75% will recur within about 2 years. But I do think it's important to note that studies of the data available to us, both in the United States as well as internationally, have shown that increased numbers of ovarian cancer survivors have been seen. This is due to both a decreased incidence of disease as well as improved treatment outcomes. A review of data from the United States has shown improved survival of ovarian cancer patients. In a California cancer registry, nearly 1/3 of long-term survivors were actually those who had advanced disease. But unfortunately, we're still seeing disparities in this improvement, which are based on both race as well as socioeconomic status of our patients. So what challenges do patients identify? What do patients see as really kind of the most problematic? And I wanted to bring up here what's called Ovquest. This was an international web-based survey of patients who had been undergoing treatment for ovarian cancer. And nearly 1/3 of the patients in this survey were treated for recurrent ovarian cancer. And there were various physical and emotional symptoms reported. And I list some of them here as well as the prevalence with which these symptoms were reported. So more than 50% were noting peripheral neuropathy, fatigue, sleep disturbances. Nearly 50% had emotional distress. This could include depression and/or anxiety or a fear of recurrence. But patients also noted pain, sexual dysfunction, gastrointestinal or GI issues, as well as cognitive difficulties. I'm again so pleased that Dr. Berry is able to join me today. She herself has done a lot of work on this specifically in our patient population. So I'm going to have her present this data that we're including here.
It'd be best if I came off mute. So, so these are fairly recent results. These are symptoms reported by 1,039 patients with gynecologic cancers. So it includes ovarian and uterine and cervical, and not just ovarian, but I think the majority we would have seen in ovarian. This is from this is from the year of when we implemented this question and intervention to support our patients through March of 2025, so 2024 to 2025. You can see, and it's the font is small, but I'll point out to you the highest incidence of symptomatology reported by our patients is the impact on sexual activities and interest. And that's this blue bar right here, 703 out of the 1,039. But followed very closely by fatigue in this blue bar here. You can also see physical function, which a lot of times goes hand in hand with the fatigue level. And then you can see the others. These are symptoms that our patients say are moderate to severe. So it's a good proportion of the symptoms. And this is since we're doing this throughout the entire population of our patients in the clinic at Montlake, and we're also now doing this at the Fred Hutch. However, I don't have those data to share with you today. We're working on that. We'll have it soon. But I wanted you to see how many patients, not participants, they're not in a research study. This is just people in clinical care are experiencing moderate to severe symptomatology. And it's not a trivial number, and it's something that we need to address pretty readily when we see our patients. So, yeah. So there might be some questions on that later, but let's
Absolutely.
go forward,
And I
Dr.
think
Urban.
just to as I move forward, I'm going to be alternating my screens between both talking about some of these symptoms and potential interventions, but then also based on Dr. Berry's excellent suggestion, how patients and or their caregivers or family members can bring up these symptoms if there's questions about them. So I'm going to start with fatigue. Fatigue is tricky in that it can extend from months to years after treatment has concluded. And although, while it's important to rule out contributors to fatigue, which can include sleep disturbances, anemia, nutritional deficits, emotional distress, this can be really, as Dr. Berry noted, a really persistent issue. Some potential interventions have been proposed and studied. This was based on a write-up that was based both out of ASCO, which is otherwise known as the American Society for Clinical Oncology, as well as the Society for Integrative Oncology, have been found to be useful in trying to improve fatigue or reduce it. This includes physical activity. This can include cardiovascular training and or resistance training. Cognitive behavioral therapy, which I like to think of as talk therapy, mindfulness-based programs, physical activity or movement programs based on Eastern medicine, such as Tai Chi or Qigong. And then also a supplement known as American Ginseng. There is some weak data suggesting that there may be a benefit to this. So I think I'm going to leave to Dr. Berry. How can we bring this up? How can we recommend our patients bring this up with their doctor?
Yeah, so just a quick background for this. We spent about 8 years testing this in multi-center cancer centers in the United States, testing what would happen if we coached our patients on how to take care of their symptoms at home, but also coached them on how to talk to their providers about it. And we found that the people who were in that intervention group had substantially less symptom distress. So that's an interplay between the patient and the provider, what happens. So in this case, with fatigue, we coach our patients to say, my fatigue is, for example, 7 out of 10. And where 0 is no fatigue at all and 10 is the worst you can imagine. And then, for example, you want to say, the fatigue has stopped me from exercising at all, or I can't even clean my house, and it's gotten better or worse. Choose what it is, and what do you recommend to deal with this? And that final question is really important because it engages your provider in what's your experience and what you need to do going forward.
So similarly, we also have chemotherapy-induced peripheral neuropathy as a very common side effect. The incidence of this as related to cancer is primarily due to the inclusion of paclitaxel as a cornerstone of ovarian cancer treatment. And although there are similar drugs to Taxol, unfortunately, even when we change from the paclitaxel to a different agent, that doesn't usually impact the incidence of neuropathy. In a small review of patients who were on a clinical trial for ovarian cancer, changing paclitaxel to what's called docetaxel, a very similar drug, didn't impact the incidence of the neuropathy. And the incidence ranges anywhere from 30 to 70%. But nearly half of survivors report that they have symptoms anywhere from 2 to 12 years after diagnosis. And this can include, as you all may know, a numbness, a tingling, or a pain in what's called a stocking and glove distribution. So some discomfort in your hands or feet. In terms of options that may be available to treat this, so those that are pharmacologic, meaning medications, can include a drug called oral duloxetine. This is one of the most researched drugs that have been found to have evidence suggesting a benefit. A class of drugs called serotonin norepinephrine reuptake inhibitors. These are drugs that are sometimes used for mood but can help with pain. And then topical therapies. This can include topical lidocaine, capsaicin, diclofenac, and then also a compounded combination of two drugs that are known as ketamine and amitriptyline, both neuromodulators. For non-pharmacologic therapies, those that have been studied and found to have some benefit include exercise therapy, again, cognitive behavioral therapy or CBT, acupuncture, physical therapy, and then there's also been some data on what's called transcutaneous nerve stimulation. So doing some very low level electrical nerve stimulation as a means of helping that symptom.
Yeah, so here's another suggestion for when you're experiencing that peripheral neuropathy, even if it's painful or not what you would think of as painful. You can say, I've had a little or a lot of tingling in my, you can say, hands, legs, feet. It started, and it's important to let your providers know when it started and whether it's become better or worse since you were seen last. And I will say that the effect of the taxanes is mostly cumulative. So what we see in the peripheral neuropathy is typically an increase over time. And our providers, when at the UW and the Fred Hutch now can see over time what you've reported for us in your peripheral neuropathy experience.
I'm going to turn next to pelvic health. So, patients with gynecologic cancers in general and ovarian cancer specifically very often have altered function of the pelvic organs due to surgery as well as subsequent therapies. So, this can manifest in changes in urination, changes in bowel movements. Some interventions that can be helpful can include pelvic floor physical therapy. This is a specialized form of physical therapy designed to improve the core and core strength as well as muscles of the pelvic floor, which I like to think of as the bowl of muscles that support the pelvic organs. This can also include an evaluation with our specialized colleagues in urogynecology to deal with urinary or fecal incontinence. For patients who have changes in bowel movements, this can sometimes be impacted both by chemotherapy as well as surgery. There can sometimes be a role for antidiarrheals for chronic diarrhea, fiber if there's been prior colonic resections, as well as dilators and/or vaginal moisturizers for vaginal atrophy and scarring. Menopause can often be an issue as well. So, for surgical staging for for epithelial ovarian cancer, this nearly always includes removal of tubes and ovaries. And although many patients with epithelial ovarian cancer are postmenopausal at diagnosis, the average age in the United States is in the early 60s, survivors may also be pre or perimenopausal. And these symptoms can include vasomotor symptoms. These are the classic symptoms such as hot flashes or night sweats, cognitive changes, vulvovaginal skin changes, discomfort with sex, and/or reduced libido. For management of menopausal symptoms, can hormones be an option? So one option here is systemic estrogen therapy, meaning this is taking either a pill or a patch to give estrogen to the entire body. Whether this is an option really depends on your epithelial ovarian cancer subtype. So it's really important if you're thinking about this to review this with your doctor. But in a prospective study of patients with epithelial ovarian cancer who had a subtype where estrogen therapy would be allowed, patients using adjuvant hormone therapy had improved quality of life. And most importantly, they did not have any reduction in their cancer survival. Other options can include local estrogen therapy, such as vaginal estrogen, and there are also non-hormonal options for the management of these symptoms, including, again, SNRIs, such as a drug called venlafaxine or Effexor, SSRIs, these are selective serotonin reuptake inhibitors. One of this is paroxetine or Paxil. But other drugs that are available include gabapentin, and a newer drug that was recently approved is fezolinetant. For sexual health, so this is a really challenging area, I think, especially for female patients. And this is because sexual function in the female body is very complex. I like to think that, sexual function for biologic males is a little more linear. There's a start and a finish. And females is more circular. There's a lot that goes into it. And in female patients, and in patients in general, there's really three domains of sexual dysfunction. This includes sexual interest or arousal disorders, difficulty achieving or having a reduced intensity of orgasm, as well as with the third being discomfort or pain with vaginal penetration. And I'm going to let Dr. Berry give some suggestions as how to bring this up. This can be a really challenging thing to share with patients. It can add a lot of vulnerability, but please know that we definitely want to give you tools to address this with your provider.
Yeah, I'm so glad that you showed that last figure, Dr. Urban, because it incorporates the emotional and libido and the other than physical, and there's a lot other than physical challenges. So one thing we suggest is you do talk about the physical. I've noticed that having sex has become painful or difficult, or however you want to describe it. And and also to say, I'm concerned that I have less interest or no interest in sexual activities. And it's gotten what, better or worse. So again, for all of these symptoms, that's important to say. And I have to say that this is the most frequently reported side effect in our patients with gynecologic cancer. But it's also, if you believe this, and I'm telling you it's true, it's the most commonly reported side effect in all cancers. And we've done our studies in solid tumors, hematologic cancers, all kinds. It remains a really big deal. So we're hoping that we can have resources at our facilities to address this.
I did want to bring up just a few options. Should people be interested? So for patients who may have struggles with sexual interest or arousal disorders, some interventions that have been studied include psychotherapy, flibanserin, which is a prescribed medication. There's been some increasing data on the role of testosterone in women. For patients who have difficulty achieving or reduced intensity of orgasm, CBT or cognitive behavioral therapy can be helpful. Directed masturbation with the help of a therapist, and I listed the AASECT in the corner. This is an association of sexuality educators, counselors, and therapists. If you're on a particular antidepressant, you may want to change it. SSRIs can have some reduced sexual side effects. If you have discomfort or pain with vaginal penetration, thankfully there's a lot of topical therapies available, including daily vaginal moisturizers, vaginal estrogen, topical numbing, so that then you can use a dilator, lubricants for intercourse, a violet vaginal dilator, as I noted, pelvic floor physical therapy, and then a newer drug called espemifene, which also can be helpful when there's discomfort with vaginal intercourse. I'm going to turn next to mood disruption. So, depression and anxiety in cancer survivors is very common. So, and then specifically in the gynecologic cancer population, more than 85% of patients will report some level of psychological distress. This could absolutely be in part due to the fear of recurrence, and then other physical conditions such as pain or fatigue can cause or worsen depressive symptoms. Some of these interventions, and I'm going to name drop a couple that we've done through our division, include things like mindfulness therapy, again CBT, cognitive behavioral therapy, talk therapy, but also physical exercise, and then potentially considering things like antidepressant and or anxiolytic medications. And I'll let Dr. Barry give some suggestions as how to best bring that up.
Yeah, so I think you're getting the gist of these suggestions, saying that what your own experience is. I notice that I am pretty down about everything in my life, for example, and I don't even want to go out of the house, for example, or I don't want to see my family as often, for example, and it's become better or worse since I saw you last. And then what do you recommend to do with this? So there you're getting the same. If you can memorize this approach to your reporting your symptoms, you're doing pretty.
I did want to just bring up two supportive care interventions, one of which has recently been concluded. This was the Living Well study. This was a web-based mindfulness program for ovarian cancer survivors. It found that greater psychological flexibility was associated with less anxiety and depression, and that we could really try to, it identified avoidance and cancer-related worry as ways that were found to be associated with distress. And this could be addressed maybe in further workshops. And then an ongoing intervention through Fred Hutch is the HOPE intervention. This is a mindfulness intervention to manage feelings of hopelessness and helplessness. And the HOPE intervention utilizes something called ACT, or acceptance and commitment therapy. This is a type of mindfulness and awareness approach within cancer therapy that targets emotional distress through acceptance of difficult thoughts and emotions. In ovarian cancer patients, an ACT-based intervention did find improvements in anxiety, depression, and psychological distress. And in a large study of patients with all types of cancer therapy, ACT interventions improved psychological distress, psychological flexibility, quality of life, and a sense of hope. So mindfulness therapies, like talk therapy, can sound very vague, and I think it's important to note kind of what are the components within cancer treatment that can be particularly helpful. I did want to bring up just some potential resources. The Foundation for Women's Cancer is a patient advocacy group that pairs with our physician subspecialty group. They have a lot of online educational courses and webinars, many of which that talk about some of these elements we covered today for your own reference. And at that point, I'll stop ours and take questions for both myself and Dr. Berry.
Oh, thank you both, Dr. Urban, Dr. Berry, for that nice overview of symptoms. Very complex, not an easy tackle. One question has come up, and please continue to put more in. Was someone clarifying that the comment that peripheral neuropathy can begin after chemotherapy is completed, or will it always start when chemo, if it is going to occur?
Dr. Berry, do you want to start with that?
Sure. So he's not a postdoc anymore. He was a postdoc, who studied this extensively, and he found out that the peripheral neuropathy is typically starting by 6 weeks into chemotherapy and progresses after that. Some women would have the same level that they experienced at 6 weeks, but many of the women, it continued to get worse. So could it start after chemo's completed? I think it's possible. I don't think it's likely. I think it's more likely it's going to start during the cycling of the chemotherapy. And that's, Dr. Gray or Dr. Urban, that may be your experience too.
I'm going to just do the follow-up question, which someone just posted. So, Dr. Urban, Renata, what can folks do to help prevent peripheral neuropathy during chemotherapy, and maybe specifically call out the ICE compress trial?
Absolutely. So I think just to build on what Dr. Berry said, for the most part, neuropathy will start while on treatment, but I think it can start shortly after completing treatment, and sometimes the symptoms can be very vague. And so that's why an awareness that it can happen, and then letting your provider know, even if you're not sure if the symptoms are neuropathy, but saying, I'm experiencing this, could it be neuropathy, I think is helpful. And to the question of what can be done to prevent neuropathy from happening. So there have been some studies, not just in gynecologic cancer, but also in breast cancer, looking at both the use of what's called cryotherapy, so using cold over the hands and feet, as well as compression. And really the physiology there is that we're trying to decrease exposure of our really tiny fiber nerves in our hands and feet to those chemotherapies. And in fact, Dr. Gray mentioned right now we have an ongoing supportive care trial called the ICE Compress trial, which is being run at one of our clinics that is looking at various means of trying to intervene to prevent neuropathy. Those interventions include using a combination of cold and compression, compression constantly, so just constant pressure, or intermittent pressure compression. And really the goal there is how can we support our patients with the most effective and most tolerated therapy to prevent neuropathy from happening?
And another follow-up question to that I get a lot of, are there any vitamins or other things such as amino acids that could help with preventing neuropathy or treating neuropathy?
That's a really great question. And although I didn't list all of the options on my slide about neuropathy, that particular write-up from ASCO and the Society for Integrative Oncology listed a lot of options, many of which don't have any data suggesting a benefit. So at least to date, there's not any supplements that taking along with chemotherapy has been found to use or found to reduce the incidence or severity of it. Looking at the treatment of neuropathy once it has happened. Again, there's a long list of supplements, some of which have been found to have very mild benefits. This can include things like alpha lipoic acid, doing glutamine supplementation. But again, the data is very, I would say, weak. And when I say weak, it's not just how strong the evidence is, but how much of a benefit there is. And thank you to the patient who shared their patient experience of using ice packs on their feet during chemotherapy.
One other kind of follow-up question, I don't know if it was addressed there. What about, there's been two new medications put out to help deal with hot flashes on the market. I'm forgetting their names right now. Are they safe to use when patients are on chemotherapy? And I apologize that I don't have the names off the top of my head.
That's a great question.
Yeah.
One of them is fezolinetant, and so that's one of the newer ones that were approved. The main issue with that one is it has been reported to cause some transaminitis, which is essentially inflammation of the liver enzymes. So it is safe to use while on chemotherapy, and essentially while on chemotherapy, you're very often going to have your liver function tests monitored. So yes, it is safe to use. I think it's just important that you talk with your doctor about that. Thank you so much, Danielle and Judith, for providing those commercial names. So fezolinetant is Veozah. And then Linquit, I have to actually apologize off the top of my head. I'm trying to do the mental gymnastics to get that to the other drug. I think that's ospamifene. But that one similarly, also safe to use during chemotherapy, but does require some monitoring in terms of, I believe, also both liver and kidney parameters.
Thank you. Yeah, the second one just recently came out, the Linquit. Yeah, and so, but I think it's really important that on both of those, although the effects on the liver, they just need to be monitored because, of course, all chemotherapies can have an effect on the liver, so it needs close monitoring. Okay. I think we went through all the questions for this section. Are there any that are coming through the chat? I don't see that. Okay. Well, I think then we can move on.
Thank you, Dr. Berry.
Thank
Okay,
you.
so
And have a great seminar.
Yeah. Thank you. Okay, so we're going to switch gears a little bit again, and I'm going to give just kind of a brief overview of just a patient-centered intro to clinical trials. And this is not meant to be, of course, comprehensive. It's just kind of just a primer, just because you hear a lot about that term clinical trials, and I just wanted to give a little bit of an overview. So let me just 1 second here while I share my screen. And 1 minute to pull up my sorry, I had too many things open here. 1 second. I am sorry about this. Share.
Dr. Gray, do you want to have read through share slides? Oh,
I have it now. Okay, sorry, I just had a little
and I can
trouble
see
there.
your
So
slide.
can everyone see? Okay, perfect. Okay, and let me just get into presenter mode. All right, oops. I am just, I'm sorry, guys. Okay, here we go. Okay, so just kind of giving an overview of clinical trials. So first of all, kind of what is a clinical trial? Well, so clinical trials are research studies, and they really can have a variety of purposes. They can be used to test new medicines. They can be used to test new treatments and or devices as well too, for a lot of our surgical and other therapies. And clinical trials are really looking at better ways to either prevent, diagnose or treat disease. And it's important to note that patients are volunteering to participate to help themselves and others. And why are clinical trials so important? I mean, I'm passionate about clinical trials. I think it's really the most important way to help move science forward. And it really is our blueprint to be able to find both better and safer treatments. And as I had mentioned in the beginning of the talk, when I started 25 years ago, we had none of the therapies that we use currently modern. We just had the chemotherapies and even not even half of them. And all of those drugs and therapies have come to be available through clinical trials. So it really helps advance medical knowledge. It also can provide better quality of life for those who are on the trial. It also helps us understand the safety and the effectiveness of medicines in a controlled fashion, and it can offer access to new treatment options that are not available yet commercially. And again, most current treatments that we have in oncology exist because of clinical trials. So who can join a clinical trial? So if any of you have been approached or have been on a clinical trial, all of them have these rules about who can join, and it's called eligibility. And these rules are really important because they're how we can keep patients safe and how we can also interpret the results of the trial. The rules can be kind of challenging because they're a little bit strict, but they really are important to be able for us to be able to interpret the results of the trial. So for example, sometimes eligibility criteria are specific to a certain condition, like you have to have a very specific type of ovarian cancer, such as high-grade ovarian cancer, serous ovarian cancer. Usually you have to have pretty certain health criteria, meaning that if you have, pretty severe liver disease or pretty severe heart disease, you probably are not going to be a good candidate for a clinical trial because the results may be difficult to interpret and not as known about the safety of the drug in patients with maybe more challenging medical conditions. You choose to participate voluntarily. You're not put on a clinical trial without your knowledge. And this participation is always your choice. It's incredibly important to emphasize that. We want patients to be on clinical trials who are choosing to be there. Don't do it for anybody else but yourself. And you can choose to leave the trial at any time. That's always your choice. Trials have very specific designs, and the trial design is really the plan for the study. And it tells you what treatment is given, how long the study is going to last, what tests or visits are needed. And when you meet with the study coordinators, they can go over that very thoroughly. And the plan is really important because it's created so that it's fair and it's safe, and so that all the patients on the trial are getting the exact same treatment, tests, interpretation of those tests. So then we can look at that population and understand what happened to that population, not just an individual. So as Dr. Rimel had talked a little bit about in our first talk, there are different types of clinical trials, and we call them phases of trials. So phase 1 trial are beginning trials, and it's really looking at, is this drug or therapy safe? Generally speaking, phase 1 trials, all patients will get the study drug. You're not what we call blinded to the drug. And a lot of times the phase 1 trials, we don't even know the correct dosing yet. And so how the design is that patients are enrolled at kind of a lower dose or, a lower to medium dose. And then we gradually increase the dose with different patients to know what's going to be the optimal dose for that drug. Phase 2 studies vary a little bit, but it's really asking the question, does this work? Is this an effective treatment for this cancer and what we're talking about? And many times it'll add this new drug that kind of passed its safety tests in phase 1 to a known treatment. So for example, as we talked about in some other earlier talks, pairing the new drug like mirvetuximab with a known therapy like bevacizumab and looking at that combination and saying, okay, does this work? Okay. And some phase 2 studies are what we call randomized, but a lot are not. A lot of them, all patients will get drug, and I'm going to talk about randomization in a second. Phase 3 studies are our gold standard for us to be able to then come to the federal government and say, this should be the new standard of care, or this should be a new treatment offered for patients. And it's really asking, is this new therapy that we designed, is it better than the current treatment? And this is really what drives the science. Phase 3 studies are our cornerstone of kind of understanding and advancing new medical knowledge. So generally speaking, in phase 3 studies, patients are randomized to receive the new treatment versus the standard therapy. And, not all phase 3 studies are what we call positive trials. We sometimes do these very large phase 3 trials looking at a new therapy compared to an old therapy. And at the end of it, we find the new therapy actually isn't more effective. That's called a negative trial. And it's really important because we don't want to, as important as it is to push new therapies that are going to be beneficial and helpful to patients, we also don't want to push new therapies that are not helpful and not going to benefit patients and potentially cause more side effects. And phase 4 trials, generally those are kind of these larger, after a phase 3 has completed, it's usually the pharmaceutical companies kind of look back about long-term safety after the approval of the therapy. So when you do enroll into a clinical trial, you'll hear about these two different groups called a treatment group or a comparison group. And a treatment group, generally speaking, is the group that is going to be put into the experimental or the experimental arm. They receive the new therapy. A comparison group are the folks who get placed into the standard of care treatment, or sometimes what's called a placebo treatment, which is when you don't give a therapy. In oncology, it's very rare to have a true placebo trial where someone's getting a therapy and then the other group is not getting any therapy. The placebo treatment may be that two groups are getting a certain therapy and then like a maintenance therapy, immunotherapy, PARP inhibitors, some of the patients are getting that therapy and some are not in the placebo group. But obviously in cancer therapy, we're very careful about who is getting placebo or not. There's another term called random assignment, and random assignment is incredibly important to protect the integrity of the trial. So patients, when you enroll into a clinical trial, if you're in a trial that has 2 study groups, you're randomized by chance into which group. You don't get to choose which group you want to go into, and your provider can't choose that group, because that's what's called bias, because you really want to kind of minimize the chance of saying that a treatment is effective due to something other than just chance. It keeps the study fair and unbiased, and again, you and your provider don't get to choose which group you go into. What to expect if you join a clinical trial? Well, you might receive the study treatment or you might receive standard of care. And for many patients, because a lot of these study treatments aren't available, standard of care might be what you're going to be offered anyway by your provider. So this is an opportunity to either get what you were going to have otherwise or this newer therapy. You'll get regular checkups and tests, and sometimes they're a little more frequent because we're trying to look at a lot of safety signals. And you always have ability for providers to answer questions about how you're doing and how you're feeling. You will always be informed about what's involved, and sometimes things change on clinical trials, and you're always informed about that. And you have your health very, very closely monitored, usually a little bit more so than when you're on just standard treatments. So what are the benefits and risks of joining a clinical trial? Well, the benefit, as I said before, is that it's the opportunity for you yourself to potentially have access to a new treatment. You also typically get a little bit extra medical attention, meaning that there's usually a little more intensive testing, laboratory, again, focusing to make sure that there are no new safety signals or things like that with the trial. For a lot of patients, the benefit is altruistic. You know that by joining a trial that you are going to be helping future generations of folks who may be experiencing the same disease that you have. And it also, for a lot of people, it really feels empowered. It feels like they're really empowering to go and be part of this broader picture. And for you personally, the benefit might be that you have better cancer control on the trial. Risks. There can be side effects that we know and side effects that we don't exactly know yet when you join a trial, particularly for the phase 1 studies, because those are, again, focusing on the safety of that new drug. The treatment might not work for you. It might be this new exciting drug, but it may not really personally benefit you. And as I said, although the benefit might be getting extra medical attention, the downside is extra medical attention, so more clinic visits, things like that. Well, what do we do to keep patients safe on clinical trials? Well, we do a lot. These trials are very intensely regulated. We do careful study review by experts before we even put them out there for patients to join. They undergo very intense review by our institutional review boards, by very high-level cancer consortium reviews to make sure that this is appropriate. This is an appropriate trial to offer patients. We do very intense, we call informed consent process. For any of you that have been on a clinical trial, that's sitting down with the provider or the PI on the trial and going over all the details of the trial. And then there's ongoing safety monitoring. So in the background, not only are you personally being monitored what's going on, but the larger group is being monitored by these data safety monitoring boards. And if there starts to be a signal like something that we didn't know about, they can quickly close the trial or pause the trial while we make sure or investigate that that's not something that's harming patients. What are your rights as a participant? You have the right to ask questions at any time. You have the right to understand the study before joining. You have the right to say no. Say, you know what, this trial just really isn't for me. Or if you're on the trial at any time, you can leave the study. You can choose to come off the trial. And of course, you always have a right to receive respectful and confidential care. What questions should you ask before joining a trial? Well, you kind of want to basic questions. What is the purpose of this trial? Like, what is it really looking at? What are the risks and benefits? What costs might be involved? We really try to make sure that trials are not going to increase costs for patients, but I do think it is an important question to ask the principal investigator. And then also, how might this affect my daily life? If I get randomized to this new study, what are the new side effects or toxicities that I might experience? So at the UW Fred Hutch, we do have a very robust clinical trials program that I'm the director of. We, in addition, partner with, there's a group called the Phase 1 Clinical Trials Group of the Hutch that also runs all of the Phase 1 trials for all of the different cancers, not just GYN cancer, breast cancer, and we're closely linked with them too. I haven't listed all of their trials because it's very extensive. And then we also work closely with a group called the Cancer Vaccine Group. One of my partners, Dr. John Liao, is very embedded in their program. It's run by Dr. Nora Desis, who's world-renowned in breast cancer vaccine research. And so we do have a huge a plethora of trials to offer patients. I just wanted to highlight a few of the trials that we have open right now in our group. As Dr. Urban mentioned, the ICE Compress trial is for folks looking at these three different ways to help prevent peripheral neuropathy for patients who are receiving first-line platinum-based chemotherapy. Other options we have for ovarian cancer in the first line or when you're first receiving chemotherapy is a study that's looking at, again, relevant to what we talked about earlier, if you're a patient who's eligible to go on a PARP inhibitor after first-line chemotherapy for ovarian cancer. Right now, the standard is 2 years of maintenance therapy with a PARP inhibitor. And this study is based on other disease sites that there may be data that you don't need 2 years of maintenance, that maybe 1 year is just as effective and obviously would have less toxicity. So this study is looking at 1 versus 2 years of the maintenance drug. We also have several trials open in what's called the platinum-resistant ovarian cancer group. For those of you that have been in that group, that's for patients who have had multiple rounds of platinum-based chemotherapy, usually carboplatin, and at some point, if the cancer becomes resistant to that, then we have to look at different options or different treatments. And so we have 2 trials in that space. Both of them are looking at standard chemo versus one of these newer ADCs or antibody drug conjugates that Dr. Rimel had alluded to, Rejoice and Rainfall. And then lastly, we also have a trial that's not open yet. We're hoping it's going to be open in February. Dr. Liao is the PI, and it's an oral therapy called an oral CHEK1 or oral check inhibitor, not CHEK1, check inhibitor for patients with platinum-resistant ovarian cancer. And then lastly, as Dr. Norquist had alluded to, we also have a preventative trial called the SOROC trial that is looking at removing of the fallopian tube only or the fallopian tube in the ovary in patients with BRCA1 mutation. Okay, so I think with that, final thoughts. Clinical trials are a personal choice. They are vital to driving medical progress and improving outcomes for patients. If you're interested in participating in a clinical trial, please reach out to your provider or you can reach out to us. We are happy to do kind of clinical trial consults where we just do a quick meet with you to kind of talk about what we might have available here. And those can be telehealth typically. I've put some numbers down there, email as well too of our research group. And I think Dr. Rimel also had some numbers in her slides as well too. And I think with that just leaves me, I'm going to stop my share and see if there's any questions.
Thanks so much, Dr. Gray. There's a question here that I think is actually really helpful is, are there clinical trials for primary peritoneal carcinomatosis? And I think that speaks a little bit to how do you figure out whether you might be a candidate and how that can be researched?
Yeah, that is a great question. I think that goes back to, we tend to use the term ovarian cancer, and that usually refers to epithelial ovarian cancer, which also encompasses fallopian tube cancer and primary peritoneal cancer. So if you've been diagnosed with fallopian tube cancer or primary peritoneal cancer, you're usually kind of under the umbrella of ovarian cancer for most clinical trials moving forward. So if your question is like for a specific, is there a trial looking at helping a term called carcinomatosis, that we don't have a trial specifically for that clinical situation, but you might be eligible for trials based on your diagnosis. And I hope that might have helped that. Okay, so I think what time are we at? So I think we are at time to introduce our next two guests. Okay, Renata, I'll let you, I think, do you know, I'll introduce. I think we're having Shanon speak to us next. Hi, good morning, Shanon. So, hi, and we have Shanon Zorrilla from, well, I'll let you guys in. You're going to go first, Shanon, and then Tracy, to talk a little bit more today about two important areas of advocacy. So welcome again, both of you, for joining us, and looking forward to hearing what you have to say to us and to our patients.
Thank you so much. It's an honor to be here. I'm excited to talk about NOCC and what NOCC offers. Would you like me to share my screen?
Am I still sharing? So I'm sorry if I am.
Second.
I know I had the same thing. It's hard to.
So it's nice to meet everyone. My name is Shanon Zorrilla and I'm with NOCC. So today I'll be talking about the programs and services that the National Ovarian Cancer Coalition offers. Okay, can everyone see my screen?
Yes.
Okay, perfect. Well, it's nice to be here. Again, my name is Shanon. I've been with NOCC for about a year, and we offer so many amazing resources for ovarian survivors and caregivers. So I'm here to talk a little bit about them today. So NOCC is a nonprofit organization that supports ovarian survivors and caregivers. Our main mission is to save lives through the prevention and cure of ovarian cancer, and to promote quality of life for those we serve. So we offer a variety of both programs and services because our main mission and vision is to see a future where no one loses their life to ovarian cancer. So some of our resources include a peer support group. So our support group is called the Teal Hearts Network, and within this support group, we connect survivors with hope, comfort, and a supportive community. And we are a national-based organization. So even though we are located in Texas, we serve all states throughout the US. So not only do we have support groups for young adults, newly diagnosed, etc., we also provide a caregiver support group because we know we like to provide that mental health service for those that care for ovarian survivors. So that's just another one of our support groups. And then you may find our phone number here, or you can scan our QR code, or even visit our website, ovarian.org. And then some other support services that we offer are our ovarian cancer care package, our Faces of Hope tote. So we offer a newly diagnosed tote as well as a recurrent tote. And you can order these online through our website. It's super easy. You just fill out a form, or you can email us at facesofhope@ovarian.org. And we also, something else that's really amazing is we offer our ovarian care packages to facilities, hospitals, or clinics. So you can also fill that out if you're interested in receiving our care package for your workspace. And then another thing we offer is the meal delivery program. So we offer meal delivery programs to survivors and caregivers, and they are free, healthy meals to support you and your caregiver during your ovarian cancer treatment. And that is also located on our website. Super easy form to fill out, or you can call us and we can help you fill it out if you have trouble with technology. And then lastly, we also provide our financial assistance program. So we offer this once a month. It's first come, first serve. And what our financial assistance program is, it helps reduce the barriers associated with ovarian cancer treatment and clinical trial participation by providing financial assistance for non-medical expenses. And that is also listed on our website, and it opens the first of each month, the first business day of each month at 1 p.m. Eastern. So that's just a couple of the resources NOCC offers, and then as well as some educational programs, our animated patient guide, our online education programs. We also have our Rejuvenate, our in-person educational programs, depending on the region that the person lives in. And then you can also always get involved through our website or any of the information listed here. We have our run walks, usually in the fall. And these are just the regions we support, as well as the emails, the states we serve, and the phone number. So those are just some of the couple things that NOCC provides. Again, you can feel free to scan any of the information listed here to find out more about our programs or services, or feel free to call us and we can talk one-on-one to discuss these programs. But thank you guys so much for allowing us a voice in this program, and hopefully we can connect with more people and let other people know about our resources. So
Thank you so much, Shannon. That's really important information, and really important to emphasize that just you are not alone. There's a lot of folks out there who are want to help and know how to help, and that if you're not even sure where to begin or what you might need, these are really amazing resources. Please reach out. Thank you so much, Shannon, for providing that. And then we'll switch over to hearing from Tracy more about her work with the Ovarian Cancer Research Foundation.
Thank you so much. And what a wonderful presentation and conference. It's really been wonderful to participate.
Thank you.
Thank you for including us. Let me share my screen really quickly. Sorry, you all get to see the beach. I hope that's a good thing. And I'll do this really quickly. Okay. So OCRA, I don't know if you can see, am I blocking this?
We can see your slides.
Oh, good. Thank you. So OCRA really, our focus is advancing innovative research, advocating for legislation, and then providing support for anyone who's been diagnosed or caring for someone who's been diagnosed with a gynecologic cancer. To date, and I think when you think of Ovarian Cancer Research Alliance, we've invested about $137 million in scientific breakthroughs. We've been able to, through our advocacy, help secure $3.8 billion in federal research and education funding. And then we're helping about just under 100,000 people each year with our support and education programs. And when you think about support and education programs, we've got three main pillars: access to care, education, and support. When you think about access to care, we've got a Find a Doctor tool. I was listening to Dr. Norquist's presentation, and we really believe if you have the opportunity for genetic testing, to definitely be involved with genetic counselors. We have a free genetic testing program. If you do not have access or your family does not have access, then if there is a result, there is genetic counselors involved. And then we also have a clinical trial navigator. There's navigators that'll help you find the clinical trials that are available for you to bring back to your healthcare team and discuss what your best options are. Our support programs, we've got a patient support line managed by oncology social workers who can help navigate and connect you to resources, a peer mentor program for patient survivors and loved ones, our Staying Connected support series, our weekly supportive sessions online, moderated by oncology social work. And we have things that are programs that are disease specific, age specific, topic specific, and also some really fun expressive arts programming, a book club, narrative medicine, and a lot of ways to be able to connect and build with community. We have one-on-one steps counseling. So it's episodic short-term counseling for 10 sessions over a 6-month period of time, psychoeducational roundtables monthly, and then we have an online community through Inspire. And I think at last count, there were about 90,000 people worldwide participating in that program. Our workshops are foundational level of science to do basic overview of ovarian cancer, uterine cancer, and advanced care planning and survivorship. Staying Current is moderated by Anameta Buell, who really talks at a higher level about genetic testing, biomarkers, and treatments that are specific to ovarian and uterine cancer. We have monthly webinars. This month is on survivor sarcoma. We've got a big international conference. OCRA sponsors the NCCN patient guidelines for ovarian, uterine, and cervical cancers. And we have a new series called Easy Science. So it's a video library on topics around actionable biomarkers and novel treatments. So most important, and I think this is what Dr. Gray had said, it's really no one should face cancer alone. And we're here. And if you have any questions, please don't hesitate to reach out. All of our programs are free. We're serving people internationally, and we really are building community. So we'll be able to connect you with others who have been there and offer you the support you need. So thank you so much.
Thank you so much, Tracy. That's just excellent. And again, I hope many of you will reach out and use these resources because I think they're invaluable. So I think we're going to wrap up in a minute. I do want to address one thing because with having such a large audience, and I think some of these questions came up, as we're talking about advocacy and all this important progress we're making in cancer, we're at a really vulnerable time in our cancer communities. We are facing massive cuts to our medical system. The the National Cancer Institute, it's proposed at the current administration to be cut by 37%, 2.7 billion. This will directly affect all of you, all of us, all future cancer patients. So this is the time to speak out, to speak up. This is so completely important. So I think there were some questions earlier. Have the budget cuts affected us? Yes, and they will continue to affect us. And more importantly, they're going to affect you and future generations of you. So please, please, please be an advocate. We all are advocates. We are trying to do what we can to reverse this. But thank you very much for your attention. Letting me just say a little bit about that.
I would, if it's okay, like to build on what Dr. Gray just said, that the current adjustments in the federal budget touch both very much research, but something that is also, I think, close to Dr. Gray and I's heart is medical education, that a lot of these cuts in finances also impact our doctors to be. So our doctors who are in training, our students, our residents, our fellows, because the majority of their training is actually interestingly funded by the Centers for Medicaid and Medicare Services. And so I think just to keep in mind that advocacy, dealing with cancer is a full-time job. But should you feel like advocacy is a place that brings you something. That can be a place, whether it's advocating for research, advocating for funding, calling your representative and letting them know, hey, I would like to keep access for telehealth, which is also something that oftentimes has been on the chopping block. So I think just keeping that in mind. I did want to come to some questions that we have in the audience. We had a question for kind of jointly for Tracy and also for Shanon to comment on the lawsuits that have been going on between a various group of plaintiffs and Johnson & Johnson regarding the use of baby powder. And I have some thoughts on this that I'm happy to share as well.
It's an interesting thing. I mean, I think it's really important to talk to your doctor to see what your doctor is reporting to you and as an individual. The OCRA has a position on this that is really reflective of what SGO has commented, and it is, again, bringing it back to your team and talking to them individually. Shanon, I don't know if you have more to add to it. We get this question all the time, and it's important to be knowledgeable, but really talk to your doctors.
No, I totally agree with you, Tracy. I think also because everyone has such a unique and different cancer journey, I think it's just definitely emphasizing, not only speaking to your doctor and healthcare team, but as Renata said, if you want seeking that second opinion too is also important in order for you to feel comfortable, but definitely agree with Tracy, speaking to your medical professional.
And I think just to build on what Tracy and Shanon said, there's been a lot of work that has gone into looking at this question of, does talc exposure increase the risk of ovarian cancer? And it's a very long and complicated answer, but to try to kind of summarize, the evidence we have suggests there might be an association. And that there is at least some evidence of a biologic relationship. And that is part of the basis in those lawsuits. The problem, though, is that a lot of those studies, we don't know what to do with that, for lack of a better word. So just to echo what Tracy said, I would strongly encourage talking with your doctor of, if you think you had this exposure, what does that mean for me? Because I think that also builds on an opportunity to say, what are my individual risk factors for this cancer? What if there's not an available screening method, what symptom awareness should I have in terms of bringing symptoms to my doctor when they happen, to say like, hey, this isn't what is the norm for me. I want to make sure I bring this up.
Great. And I think there was one, I try to scroll back through one quick question about, if you join a clinical trial and will your insurance pay for it? Most clinical trials are designed that if parts of the trial are under this, what you would normally get otherwise, like standard of care, a CT scan, a lab test, that's billed to your insurance and they have to pay for it. Many parts of the trial are in addition. For example, the newer drug, and the study sponsor or the drug company that's sponsoring the trial gives that free. You're not charged for this new drug or if they need several different tests, that's not charged. So you shouldn't bear any additional cost. Okay. So I think we want to wrap this up. This has really been great. This is our second year doing this. I really enjoy doing this patient and caregiver talk. I know we can't see you or we're not in the room with you, but feel your energy with all of the chat questions. This has just been a great experience. Thank you all for your attention. Thank you all for the speakers and really your insight and knowledge. And I really hope it's been valuable for you. Most importantly, please, please, please take the time to give feedback because we like to know what worked, what didn't work, what you would like to see in the future. And really just thank you for your time today. Appreciate that.